أشهد أن لا إله إلا الله. أشهد أن لا إله إلا الله. أشهد أن محمدًا رسول الله. أشهد أن محمدًا رسول الله. حي على الصلاة. حي على الصلاة. حي على الفلاح. حي على الفلاح. الله أكبر الله أكبر. لا إله إلا الله.
اللهم رب هذه الدعوة التامة والصلاة القائمة آت سيدنا محمدا الوسيلة والفضيلة والدرجة الرفيعة وابعثه مقاما محمودا الذي وعدته وارزقنا شفاعته يوم القيامة إنك لا تخلف الميعاد.
ऐ अल्लाह, इस दावत कामिल और ता क़यामत कायम होने वाली नमाज के रब, तू मोहम्मद सल्लल्लाहु अलैहि वसल्लम को जन्नत में नुमाया मकाम, फजीलत और बुलंद दर्जा अता फरमा और उन्हें उस मकाम महमूद पर फाइज फरमा जिसका तूने उनसे वादा फरमाया है, और क़यामत के दिन हमें उनकी शिफात नसीब फरमा। बेशक तू वादे के खिलाफ नहीं फरमाता।
जो शख्स बेटी के पैदा होने पर खुशी करे तो वो खुशी करना 70 बार खाना काबा की ज़ियारत करने से अफजल है।
तरफ से जो है एक अच्छा हमें प्लेटफॉर्म मिला हुआ है IEEE फेयर का, जिसके अंदर हम लोग अपने डिफरेंट प्रोडक्ट्स को जो है शोकेस करते हैं।
बदर एक्सपो ने हमें एक प्लेटफॉर्म दिया, वो हमें काफ़ी सपोर्ट भी करती है और यहाँ पे डिफरेंट कंपनीज को भी उसने काफ़ी सपोर्ट किया है।
I'd like to thank the dignitaries and all the guests, the sponsors, the exhibitors who have been with us through the years and have made this event possible.
It is a great opportunity for the investors and even the dealers and the distributors to participate and engage in this seminar, and I further request the management of Badar Expo to continue these seminars for the general awareness of the people.
बदर एक्सपो की तरफ से जो है एक अच्छा हमें प्लेटफॉर्म मिला हुआ है IEEE फेयर का, जिसके अंदर हम लोग अपने डिफरेंट प्रोडक्ट्स को जो है शोकेस करते हैं।
बदर एक्सपो ने हमें एक प्लेटफॉर्म दिया, वो हमें काफ़ी सपोर्ट भी करती है और यहाँ पे डिफरेंट कंपनीज को भी उसने काफ़ी सपोर्ट किया है।
thank the dignitaries and all the guests, the sponsors, the exhibitors who have been with us through the years and have made this event possible.
It is a great opportunity for the investors and even the dealers and the distributors to participate and engage in this seminar, and I further request the management of Badar Expo to continue these seminars for the general awareness of the people.
फरिश्तों को शिकायत है कि या रब बशरे गुमराह कम कोशिश भी है, नया इंसान कोई तख्लीक कर तो ये जाहिल भी है, बारे दोष भी है।
It's 1 p.m.
I would like to call Dr. Somia Iqtidar. She is a physician by specialty, a faculty at the King Edward Medical University and Mayo Hospital, General Secretary of the Pakistan Society of Internal Medicine with contribution to multiple public health projects in Punjab and across the country. Welcome, Dr. Somia. Then I want to call upon Dr. Asif Imam. He is an immunologist and internist by specialty. He is a consultant at the Aga Khan University and South City Hospital. He is the founder and chairperson board of trustees of the Sina Health and Education Foundation. Welcome, Dr. Asif. Next, I would like to call upon Mr. Javed Ali Jagrani. He is an officer of the Pakistan Administrative Services, currently leading and transforming the People's Primary Healthcare Initiative in Sindh as its CEO. If Professor Javed Akram is here, sir, Assalamu alaikum. We'd like to invite Professor Javed Akram to please join us on stage. Sir, last page. He is the Vice Chancellor of the University of Health Sciences, the President of Pakistan Society of Internal Medicine. He has served as the caretaker Health Minister of Punjab, and he's a former VC of ZEBMU and has over 40 years of experience in the health system of Pakistan. I welcome all our esteemed panelists to this session, a very key session and the first session of this Health Expo on the global primary health care and the universal health coverage and where we stand. Pakistan is committed to achieve the Sustainable Development Goals by 2030. And today in July 2025, it is a critical moment to discuss the SDG 3, which is the health goal of achieving universal health coverage through primary health care. The theme of this conference, the Global Collaborations for Better Health, reflects the SDG 17, which is the goal of multi-stakeholder partnership. With this preamble, I would like to request Professor Javed Akram Saab. Sir, from your vast experience of academics and the health system, please enlighten us on the lacunae and the bottlenecks in the two key areas, the health policy and the curriculum. The National Health Vision 2025, what it was able to achieve, the upcoming National Health and Population Policy, how it will help us achieve the SDGs, and the impact of devolution, especially in the context of the curricular reforms required for bridging the HR that can support us in establishing the universal health coverage.
एक ही पॉलिसी को आगे इम्प्लीमेंट करे, बजाय इसके कोई नई पॉलिसी बनाए, पहले अंडू करे। तो मैंने उन्हें कहा कि जी आपने ही ये ऑल पार्टीज कॉन्फ्रेंस कराई थी टेररिज्म की, और तब उसके खातिर रिजल्ट आए थे। अब आप ही ये मीटिंग बुलाएं तो वो हंसने लग पड़ेगा, ये तो हमारा काम ही नहीं है। मैंने कहा जी काम तो आपका है या नहीं है, लेकिन आप ही कर सकते हैं कि ऑल स्टेक होल्डर्स, ऑल पार्टीज, ऑपोजिशन, गवर्नमेंट, everybody, army themselves, because they are in government also, so we should all agree to a health policy, irrespective, और 50 साल की health policy दे दें कि जो आए अपना हिस्सा डाले, उसमें चेंज ना करे। So that is the only way I think that Pakistan should go.
Thank you, Dr. Javed. In the interest of time, I have to cut you a little short. So wonderful points by Dr. Javed Akram, that policy is really not the problem. It is mostly the issue of implementation, and short-lived policies do not work. They should be long-term policies which should be applied across the country by all politicians and all governance that come in. Next, I would like to request Dr. Khalid Shafi Saab. You have been spearheading many public health initiatives on your platform of the PPA, and especially in the childhood immunization category, and as the chair of the mark-e-haq. So what are some of the main health and social issues that are causing these not so good indicators in child health, and how our current immunization program and the upcoming vaccines can achieve universal immunization coverage? And one key question is, what is your expectation as chair of mark-e-haq? I would like to ask you, what is your expectation for polio and measles eradication in Pakistan? This is a very key thing.
Thank you. You have asked three things each of which needs special attention and answer. First is the health indicators. Regarding the health indicator, although there is some improvement in the health indicators, our physical age has now in the 60s, it was in the 50. Our infant mortality rate was 126, now it is in the range of 67 and 80. Lekin, in spite of this, the rate of progress is not proportionate to the efforts. First of all, the efforts are only done in the curative side. Our health policy, health budget is mainly directive towards the curative side. Look at the budget of the same in this year. Out of 350 billion approximate budget, only 16 billion is allocated to PPHI. This approximate figure, which covers 70% of the primary health care of the Sindh. And only one hospital, SIUT is given 18 billion, Indus is given 10 billion, a new hospital is built with 10 billion Larkana, and there is so much distribution of the funds all around. But for the primary health care, which is the basis of the health foundation, is so much neglected. Number one part is that. So, Dr. Javed Akram has rightly said that the government and the leaders are only interested in achieving the things. Today, if you immunize a child, the benefits will be evident over the next 20, 30, 40 years. If you counsel a mother about the breastfeeding, the result will come later. But if you make a heart transplant, kidney transplant, it will be very attractive to the people. One thing is that. So our health indicators are not improving as they should be. There was a plane crash with the PIA 2-3 years back. Now the people still remember. There is a plane crash of the Air Blue and other airlines, people remember. But daily, equal to 2 jumbo jet passengers number, children are dying in Pakistan. But attention is not being given to that. We have prepared a costed action plan for the newborn survival. Government has, Dr. Javed has rightly explained everything. We worked 2 years for making a strategy for improving our newborn mortality, which is the worst in the world. But the costed action plan is there, but it is not being implemented. Still, the government main focus is on the curative medicine, which gives early results, but this primary healthcare foundation will give later results in a long run. So this is a neglected part. This was your first question. And the second question was, remind me, that was about the immunization. Okay, the main issues which call number one is the lack of the civic infrastructure. For example, I give you an example. When this rotavirus vaccine was introduced in the EPI program, we were very hopeful that now the hospital will not be treating so many patients with the diarrhea. But still, our lack of infrastructure, good hygiene, sanitation, safe water, it is not being complemented with that. In the Western world, they have achieved attention on the health issues plus improvement in the civic infrastructure and the hygiene and the safe water sector. This is a total ignored part. Our first priority should be to provide the safe, clean drinking water to our people. There is no plan for that at all. Even the water is not there sufficient. So one factor is that. Other factors that I have just explained, that we are curative minded, not preventive minded. Second factor is from the other side, that is the demand. That is demand. There's so many good programs are there, but the people are not availing them because of the number one, poor literacy rate, lack of awareness, and lack of the sense of the health education. For example, vaccine program is there. The government purchases vaccine for every newborn who is born in Pakistan, but the utilization is less than 70%. There are other factors for that. Our misbeliefs is still, we have so many misbeliefs that of the people, we go door to door for the eradication of the polio, but the people refuse for that. So one thing is that, now coming to that, what is our expectation about the polio program, polio eradication, the measles elimination? Regarding if we take the program as a polio control program, this is a very successful program because there are very few cases of polio. But for the eradication, which is an absolute process, we have to go far beyond this. So much energies and so much funds are being allocated to polio program. Even the Prime Minister, Chief Secretary, everybody is committed. The Commissioner, Deputy Commissioner, Assistant Commissioner, Police Force, everybody is supporting to this program. But because of the misbelief of few thousand parents, still the virus is circulating. But still, we have no option. We have to eradicate the polio because the whole world is looking after us. And we have not this option that we can ignore this. It's about the polio. Second is the measles. Measles is a killer disease. We, the pediatricians, know very well this is the worst of all the vaccine preventable diseases because it has significant incidence. Unfortunately, it can be easily prevented just with 2 doses of the vaccine. First dose is given MR vaccine at 9 months, second at 15 months. But our coverage, which is start in the range of 80-85% at birth, drops to less than 70% by the 9 months of age. And this figure is complemented by the high vaccine coverage rate in the Punjab and Azad Jammu Kashmir. If we come to Sindh, it is 69%. If we go to KPK, it is 60%. And if we go to Balochistan, it is 29% coverage only. So, but the situation is so disheartening on one side. On the other side, it is not that we, the health provider or the public health specialist, we have not given up. We are still raising our voices, and whatever places at the policy level we are working, we are trying best to overcome this situation. I give you just this example regarding the NITAC. NITAC is not an executive body. It is a group which is formed by the government of Pakistan to give the policy guidelines regarding the immunization to the EPI and the Ministry of Health. Regarding in my tenure, in the last 2 years, as a chair, what we have achieved, number one, on the top of that, we have included human papilloma cervical cancer vaccine in our EPI program. This is a great gift to the female children of Pakistan. Every year, 5,000 women who are suffering from the cervical cancer die because of that. We will be saving their lives. This is a great achievement, and this HPV will be rolled out in the Punjab, Sindh, AGK, federal area on the 15th September. Every female girl from 9 years to 14 years of age will be given this vaccine, and from the 1st January 2026, it will be included in the national EPI program. In the start of the 2025, KPK and Balochistan also will have the similar campaign. This is one achievement we have done to overcoming the measles, this so much high rate of the incidence of the measles. There are many suggestions. At an ad hoc process, we are going to have an SIA, special immunization activity in the November, where all over the Pakistan, we will be vaccinating the children from the 6 months to 5 years of age. So after this, we are working, the NITEC is working on the measles elimination strategy, and we are working that we will control the measles to such a level that it will not be a public health problem. Still, it is the major vaccine preventable disease. The cases are there, the hospitals are most of the time flooded with this. These two are the main achievements regarding the NITEC. The NITEC Pakistan has recommended, first of all, I will want to share with you, now the NITEC has the vision that the vaccine for all ages, which is called the life course vaccination. Till now, the vaccination program was limited to the children under 2 years of age and the pregnant ladies. But now the NITEC has given the vision that all the people of all the age deserve vaccination, whatever is required. In the first step, we have recommended that the vaccination coverage should be increased to the 5 years of age. As an ad hoc measure, the big catch-up company is there. It is being done in Pakistan. And hopefully, this recommendation of the NITEC will be accepted by ministry. And by the 2026 start, we will be having children who miss the doses till 5 years, they will be eligible. I have 1 minute now.
We can have 2 more minutes later on, then we can continue with that. Thank you so much, Dr. Khalid. Very interesting insight that one side, the budget is an issue, that it is not directed to the right area. And on the social side, the literacy and the demand issues, and then the problems with the civic infrastructure. And it was wonderful to know about NITEC and how we can expand these suggestions and incorporate them. The next, I would like to invite Dr. Somia Iqtidar, and I would wanted to ask you that Pakistan's current demography, it basically has a youth bulge and over 15 and towards the 60 years old. For any country, this is a demographic dividend, economically speaking. These people should be nice and healthy and contributing to our economic growth. However, in Pakistan, this age group is suffering from increasing prevalence of non-communicable diseases like diabetes and high blood pressure. And as they grow, they will not be able to contribute economically the way that any country can actually benefit from this. So what is your view about the preventive and gatekeeper role of primary healthcare as compared to the curative focus that we currently have in our country? And then how do you see that in this aging population, is the health system ready to cater to them? What do we need to do? Because when these people grow up with all these non-communicable diseases, there is a huge chunk of economic burden on the country. So I think you have a presentation. Please, can you help us start that? Thank you.
Okay. So thank you very much. Good afternoon, everyone. My name is Dr. Somia Iqtidar, and we are all aging. And it's one of the life's few guarantees that we will age with every passing day. But as communities live together, are we truly ready for what this means, aging-related issues? So today we'll try to cut noise, we'll talk real challenges, real solutions, and how primary healthcare must lead the charge for true universal health coverage. So let's get started. So let's talk about numbers, because they tell a critical story, right? So Pakistan has 16.5 million people aged more than 60 years. And that's nearly 7% of us. But look ahead. By 2050, that number rockets to 40 million. That's 12% of our population and almost double of today's reality. So there are two urgent details. Women, especially over 80, vastly outnumber the men. And it's not just that it is in the cities, it's hitting the rural communities hardest, where care is hardest to reach. And this isn't a future problem. It's unfolding right now, today, because in clinics, we see a lot of old age patients with multiple comorbidities, and not only in clinics, but in rural health centers as well. So, why is aging accelerating? This is the question, and this powerful trend tells us the story. So, first, we are living longer. So, life expectancy, it jumped from 60 years, which was in 1990, to over 70 today. But secondly, fertility rates are also different. From 6+ children per woman in 1990 to under 3 today. Fewer babies, but longer lives, and this is an aging tsunami. So by 2050, this curve shows a 40 million elders which will be waiting for care. And this isn't accidental. It's actually a demographic transformation. So these numbers aren't just stats. They are people, and our system is struggling to catch up with them. And let's have a reality check. Primary healthcare isn't built for seniors. When we talk about primary healthcare, it's usually mother and child healthcare or a younger population. No geriatric training, no tailored services. And over 60% of our older, we all know that they battle chronic diseases like diabetes, hypertension, ischemic heart disease, and increasing number of hepatitis and renal disease as well. So problems are emerging and increasing. And programs like if we talk about Punjab, Sehat Sahulat, they fall short. They skip outpatient care and home health, and that's exactly what elderly population needs. So the families are drowning, especially the women, and it's a system failure. And what's the solution? Prevention, which barely exists. So we are reacting and actually not preparing for the future. There are no dedicated geriatric care facility in the country. This was stated in 2023 by Pakistan Medical Association. And that is so true. Geriatric care isn't taught in the medical schools. There are no specialized clinics for complex elderly needs. There is no structured training for post-graduation in the geriatric care as well. So the gaps are straining our entire system. This leads to uncoordinated referral systems. Rising demand for chronic diseases management puts a burden because these are lifelong diseases and they need a long-term care. There are weak social protection and many seniors face poverty, illness, which is a dangerous mix. And there are no long-term care models available. We improvise daily, and obviously, if on a daily basis you are doing this, that's unsustainable. So it's a flying blind. Without age-specific data or digital tools, we are just guessing and not saving. So this isn't just insufficiency, it's real lives in the balance, and we need to do something about it. I'm just trying to show you here about the international medical graduates in specialities in the USA. This is just to give you an idea when we compare it with Pakistan. That 51.2%, that is for of the international medical graduates in US actually go to the geriatric medicine. This is more than all the subspecialties that they opt for their training. But the situation in Pakistan is completely opposite. There is just a handful of geriatric specialists for over 16.5 million elderly people. There are only 2 formal pathways which exist. One in AKU, which runs a fellowship program in geriatric medicine. And there is a CPSP-linked, Birmingham-linked program in UK where they provide training. So this is the progress, I would say, but it's a single drop in the ocean of need. We need every medical college training geriatric experts, and we need every district hiring them because the foundation is laid, and now we have to build on this by improving our systems. So how do we scale? With 4 non-negotiable pillars: education, clinical systems, policy, and research. If we invest in them, I think we can come up with something which can help us in the future. But we also need to know that UN has declared this is the decade for healthy and age-friendly environments, and that's our primary healthcare hubs and mobile units. So we have to combat ageism by training providers to value elders' dignity. We have to develop integrated care by linking clinics, homes, and social support. And we need to have a long-term care plan by piloting the community centers. So the Pakistan's action plans aren't optional, they are a global priority because UN also demands for this. So now let's build our plan to match the international standard. And we have to shift our focus on the health care instead of sick care. Unfortunately, we are treating patients and not preventing illnesses, which is the need of the hour. So prevention starts from the pre-geriatric care. So regular and moderate physical activity since childhood has to be encouraged. The nutrition services has to be improved. We have to tell our youngsters to abstain from smoking and alcohol and avoid self-medication. We have to engage them in healthy hobbies like reading, writing, sports, and listening to music. And in some countries, they have this financial security in adulthood itself program, which is an old age social and income security program with the name OSS. So we have to start in the pre-geriatric if we want to improve the care of our elderly. So the primary prevention starts with health education. We need to improve immunization. We have to work on screening of chronic health conditions like diabetes and hypertension. We have to improve our dental services as well because they are also very important, especially in the elderly population. Exercise program, nutritional interventions, and in females and men also sometimes hormone replacement therapy is the need of the hour. Coming on to the secondary prevention, we have to screen for diseases like diabetes by doing a mass community level screening programs because diabetes has become the #1 disease in the adult population in Pakistan globally. We have to have mammography or ultrasounds of the breast for the early detection of breast CA, pap smear for cervical carcinoma, chest x-rays for lung carcinoma, fecal occult blood and sigmoidoscopy is recommended after certain age, especially with a family history for detection, early detection of colorectal carcinoma. Screening for ocular diseases, like if you have diabetes, screening for diabetic retinopathy or glaucoma, which is also very common in our population, and hearing evaluation. And these all come under the secondary prevention. Talking about tertiary prevention. So when illness strikes, recovery isn't just medical. It's just about restoring dignity we owe to our elders. So podiatric care, dental services, counseling, rehabilitation, this is all healthcare. So we have to invest in all of them in prevention and not in the cure. Geriatrics basically is not a single disease. It's about whole people with layered needs. And this is the 5Ms global model, which includes mind, mobility, medication, and what matters most, and multi-complexity. We know that old age is accompanied by multiple chronic conditions, advanced illnesses, and complicated biosocial needs. So this all has to be kept taken care of when we plan geriatric services. So I will just give few recommendations over here that what needs to change. PHC reforms. So age-friendly primary care and rural mobile units, they can be a helpful step. Then training the specialists, launching of formal geriatric programs because skills matter, and expand the Sehat Sahulat card-like programs covering home care, outpatient support, and filling the gaps. Then pilot the care centers, which is our community hubs for long-term needs, and we have to start locally and then expand. We have to invest in digital health, telemedicine for chronic diseases and mental health because technology saves time, and data system. We have to track the data, monitor access outcomes and costs, and this will help us in the long run. So geriatric team is not only doctors. We need to produce not only geriatricians, but nurses, physiotherapists, health workers, social workers as well. So I will end here by saying that investing in equitable, age-friendly healthcare systems in low and middle-income countries in particular is just not a moral imperative, but it's an economic necessity. So when we empower our older population, it enhances the societal well-being and it builds the resilient communities for future generations. So are we ready? My answer will be not yet, but we can be. Aging is a success story if we plan for it. This is a cross-cutting issue including health, gender, economy, and just not related to primary healthcare only. We must move from reactive to a proactive care model, and let's build systems that respect age, support independence, and promote equality. Thank you very much for it.
Thank you, Dr. Soumya. Very insightful information that we have to build healthcare, not sick care. And our primary healthcare system is not built for the CDs and NCDs and not for, rather for maternal and child health. So let's move on to Dr. Asif Imam. So in our mixed health system, NGOs and CSOs have been filling up a major gap in the primary healthcare service provision. You, sir, have been the pioneer of utilizing an NGO platform for delivering quality primary healthcare services through the SINA initiative. What are the challenges and the successes for CSOs and NGOs to deliver universal healthcare in Pakistan at national as well as provincial level? Or what innovations or intersectoral collaborations are needed to engage the NGO sectors to achieve these SDGs? And what is the public policy vacuum in engaging the private sector for UHC and primary healthcare?
Thank you very much. My name is Asif Imam, and although I'm an allergy immunology specialist, but my passion is primary healthcare. And actually, I moved from the US to set up a robust system of primary healthcare. So, as we all know, WHO says that 80 to 90% of healthcare needs can be met at the primary healthcare level. And if you look at Pakistan, we're just the opposite. We don't have any primary healthcare system at all. That's where the fundamental problem is. And this is what we need to address, that our foundation is actually not good. You know, we don't have a good primary healthcare. The good news is that PMDC's new leadership, they have actually sort of revolutionized the thought process of what a good primary healthcare system should be. And they are now totally focused on primary healthcare. The leadership has understood that primary healthcare ke baghair kuch nahi hoga. So right now, PMDC is trying to revamp the curriculum in which the training of the graduates, postgraduates, because there was no primary healthcare training post-medical school. Everyone was training in the hospitals. And obviously, as you know, hospital training and the primary healthcare training is very, very different. So now what they're doing is they are mandating each medical college not to just open a hospital, but 5 primary healthcare centers for training of the students and residents. So this is revolutionary. So the trend and the intellectual process has already started. But the problem is that is the first step. So you have to change the curriculum, emphasize on primary healthcare, which will cater to 80 to 90% of healthcare needs in Pakistan. If you look at any effective healthcare system like NHS or the Canadian system, they have a very robust primary healthcare system. And this is where we need to focus and develop. So the SINA story starts in 1998 when I came back from the US and started to understand the primary healthcare system in Pakistan. And obviously, it was very obvious that we need to develop a whole system, not just do things in silos, complete system. And we presented our model to the WHO EMRO region in August 2023 as a care model of a primary health care. And it was well received over there. And since actually before we presented it, WHO has actually come up with 10 levers, operational levers of how a primary healthcare system should work. So what we have done is we have taken that 10 levers and we have developed our systems according to that. And I think we, out of 10, 9 of us, we can actually claim that we are doing that. So I think the first thing is you need a very robust model or a system with training. The good doctors are trained in that system. The second challenge was you can have a nice infrastructure, a nice clinic, and the nurses, but the nurses and the doctors are not trained for primary health care. So we have to revamp the training as well. And this is a very big task. This is something that I think our PMDC is starting to do, but I think even the medical colleges and the residency programs should start doing. So the system is number one. Second is training of the multidisciplinary approach. Like we all said that our system is doctor-driven. It has to be multidisciplinary-driven. The doctor cannot do everything. They need a support team to support and provide the proper care to the patient. So training ke baad, basically it comes on implementation of that system with accountability. So हमारे वहाँ ये होता है कि आप डॉक्टर को आपने या नर्स को आपने एम्प्लॉय कर लिया and then कोई पूछता नहीं है कि उसका परफॉर्मेंस कैसी है. So this is something, accountability has to come. Until accountability comes, don't expect any kind of quality of care. So we have worked on that in our system also. We have started with the audits of the doctor performance, and we have a very robust quality performance audit system for the doctors, and we re-educate them. If they have any shortcomings, we train them. That's the third thing. The other thing is, this is age of digitization. We need a very robust 360-degree digital platform which will integrate all kinds of care. So we are in the process of developing a multidisciplinary digital platform, especially for primary healthcare, in which the doctor, the nurse, the nutritionist, the physiotherapist, the social worker, the pharmacist will have their own domains in which they can put their documentation of what kind of care they gave to the patient. So we have to move on to the modern technologies. And once we have done that, then we should work together, and then we come up with a national standard, like NHS. See, NHS is a national standard. We should work together, all the academic institutions and the NGOs and the private sector. They should come up with a national standard of primary health care. And then things are going to start happening. So that's my 2-bit.
Thank you so much, Dr. Asif. So a shift from the doctor-driven current model, accountability, digitization of services, and as we have gone through 4 of our panelists, I think all of them are agreeing that although there's 5 years left till 2030, but the primary healthcare has huge amounts of lacunae, and we are all aware of it. So we can definitely shift towards device policies to address them. Next, I move on to the primary healthcare systems, the public primary healthcare system specifically, and the maternal and child health services. So, Mr. Javed Jagrani Sahab, who is the CEO of the PPHI, you have successfully expanded and improved the PHC network in Sindh, especially for the maternal and child health services. Please, can you share the public partnership model, this particular model, how it has evolved in Sindh, and how do you think that this model can be leveraged in our mixed health system to achieve the primary healthcare and universal healthcare coverage goals?
Thank you very much. Thank you very much. Yes, as far as PHC it is concerned with the perspective of this PPP mode. Basically, this public-private partnership that's maybe if not that much new, but in the recent past, it's a new type of management model which has achieved good results in different sectors. So with this approach, government of Sindh applied this. Initially, federal government, all of the provinces, and then Sindh government, specifically in Sindh province, they adopted this approach in health sector and particularly in the primary healthcare side. So it really has brought good results and good fruits as far as primary healthcare is concerned, because I'll just briefly touch upon why it is so, because it is addressing system issues, basic issues with which our governmental public sector system was struck up with. Why it was not delivering, why it was health facilities in far-flung areas were not delivering. So it basically, this new model whereby PPHI is working under an MOU with the government of Sindh, it addresses those core issues which were inherent in those public sector health facilities. Number one, financing model. The government of Sindh came up with under this PPP model, we have a different financing model whereby one-line grant is given to PPHI. It is PPHI who has to decide, who has to prioritize funding allocation. Before this, it obviously was different model, and prioritization was not being done. So this solution, this one-line single-line grant, really gave a space in terms of prioritizing the areas, geographical areas, services areas where by a true delivery can be done. Number one. Number two, then administrative independence. These were the two issues which were inherent, as I told you, as far as primary healthcare facilities were of concern of government of Sindh. So when I say administrative independence, here PPHI is totally independent to take administrative decisions in terms of HR hiring, in terms of aligning services with the modern day approaches and all that, which was missing earlier. So with these few but basic inherent issues addressed with this PPP approach, obviously there has been a topsy-turvy change as far as PHC is concerned. So once I share the results, I have maybe data when PPHI started some around 14 years back, few of health facilities were handed over by government of Sindh for its management, and right now the number is 1400 plus, which means in terms of the coverage, we are managing 40% of primary healthcare as far as population is concerned, the whole of the Sindh. And in terms of rural Sindh, we are covering more than 60% of primary health coverage. So we basically came up with a new idea with same issues, and the coverage is day by day increasing. Geographical coverage is increasing, whereby PPHI is operating in all far-flung areas of province of Sindh. Maybe it's tough areas, hard areas like Kashmir, Tharparkar, Kambar district. So we are everywhere in the whole of the province. In terms of financial coverage, analyzing services being given by PPHI vis-a-vis UHC, this is another important component of UHC, that in terms of financial equity, financial facilitation, the UHC services have to be provided, keeping the financial position of the patients also. So in their terms, PPHI is providing 100% all the services free of cost, which means addressing this particular issue of UHC. In terms of services coverage, we are focusing upon all the indicators which are covered under universal health coverage, all the priority indicators, which happens to be 30. In majority of the indicators, the PPHI is providing a comprehensive and 100% package, which happens to be around more than 40 to 45%. Around 30% of indicators we are giving partial services, and there are still 15 to 20% of indicators as far as UHC is concerned, whereby PPHI is not providing those PHC services. And obviously it depends upon government of Sindh. We have taken up this particular case with the government of Sindh so that a comprehensive package of UHC is provided. to the population of government of Sindh. Having said that, the good thing is we have, like, government of Sindh has piloted one project at Tandu Alayar, whereby a comprehensive EPHS project and package has to be given at Tandu Alayar. That will be pilot, and the target is that the UHC coverage in terms of essential package of health services has to be comprehensive. All those indicators, the priority indicators in terms of service delivery at PHC health facilities has to be, the target is that all those priority services are given to clients, to patients at the health facility level. So this is really a good start, whereby we are going to digitalize services, we are making the service package more comprehensive. So in winding up my discussion, I will just say that obviously this PPP this novel approach has worked as far as primary healthcare is concerned. Number one. Number two, more efforts are required. Obviously, if the package has to be comprehensive, Sindh government, and we are negotiating with Sindh government, more health facilities, maybe 100% of primary healthcare health facilities have to be given to PPH. And once that is done, hopefully this whole UHC package will be comprehensive in Sindh. Thank you.
Thank you so much, Javed sir. So administrative independence that comes with the public partnership model has been very successful in Sindh, and if we look into this model, it could possibly be something which we can utilize, and other provinces can also utilize this model, which is solving some of the key issues and being able to administer the 3 pillars of the universal health coverage. So for the second round, we have identified all these problems, and I think we are all agreeing to it with all your expertise. We all know what the problem is. Now, if you can all just give us 2 to 3 solutions or recommendations, what should be the direction of working now in this time constraint of 5 years, trying to achieve universal health coverage through primary health care? Just 2-3 recommendations from each one of you. Sir, aap se kar.
Thank you. One thing I think we must keep in mind is that universal health care is not a luxury. It is right of every child that is born, irrespective of caste, creed, or pocket, or whatever. So far, whichever model you look at, private-public model in Sindh, this is not really a private-public model. It's more of a philanthropy-driven model. That you have people, because there are more industrialists in Karachi and in Sindh, and there are very, very rich people and too many poor people. So there are very good people who want to donate something for the base of the pyramid. So that is being, I think, used. But if you go to the rural Sindh, which I have myself gone to rural Sindh many times, I think the coverage there is, nowhere near that we need to be. I think the universal health care in Punjab, they have tried to outsource it to the private, and they failed miserably. One thing the government must realize, or be made to realize, is that it is the responsibility of the government and not anybody else. So you cannot, provide universal health care or optimum health care to people with charity. Charity is add-on. You cannot shift your entire burden of your duties to the philanthropy center. You can only thank them for doing what they are. But they are not responsible. It's the government who is answerable to the people in what they have done. Unfortunately, I think what needs to be done is that we do have in Punjab, and I am in Sindh, rural health center, basic health units, but most of them are dysfunctional. They need to incentivize the human resource for health to go into these rural areas. Then they need to pay them double or maybe triple of that. So they need to populate that. Those buildings are now being used as, so somebody has started a school there or somebody. So they are not really functional at all, majority of them. So I think to make them functional, the main bottleneck is the human resource for health in these far-flung areas, the security issues, which again it's up to the government to sort out there, and then non-functional equipment there. So and then the provision of medicine is not there. So that needs a good governance model. In Punjab, we have a model where primary health care is separate and tertiary care is separate, specialized care. It didn't work. I think it was much better when we had one health department. The most important thing I think that needs to be done, and during my tenure as a minister, we started that, is the referral system. If you have a referral system where you have catchment areas with your tertiary care hospital, the teaching hospital, and then because they are also public sector organizations, then shift the duties to them to make sure that there is adequate human resource for health, like for universities, medical universities, health universities, or for the medical colleges. We did a pilot where we attached few districts to a particular medical college, like Allama Iqbal Medical College, and then the consultants were going there weekly to the basic health units, and even surgeries were started and everything. But as always, once the government changes, everything changes, unfortunately. So there was no sustainability, but the pilot did very well. 2 years pilot in these districts, Saiwal and Okada, attached to one medical college, and that improved the situation there, the vaccination rate, the nutrition, which is a problem in children, as Khalid Shafi just highlighted. And these things, our problem is there is too much overcrowding. For example, I have been chief executive of about 12 major hospitals like PIMS. In PIMS, which is a university teaching hospital, we were doing 250 plus deliveries every day. So we are not a maternity home. So that is why I think the people look up to these tertiary care hospitals, because there are non-functional facilities next door. So that they need to be made functional.
Thank you. So 2 minutes में what should we do? क्या करें? 2 चीजें 3 चीजें क्या करें?
I will just add to what Dr. Javed has mentioned. Actually, our priorities should be focused toward the prevention. That is the only way we can get the universal health coverage. And the missing part is that all the attention is on the curative medicine. Even preventive medicine is not much taught as it should be in the undergraduate and the other curriculum. And in the primary health care, the missing part is the community engagement. And the community participant is still in the places where it is practiced. The community engagement is not there. In the Azad Jammu Kashmir, the community engagement is so strong that their 85% vaccination is done at the vaccine centers. The community is so bound that they do not miss any vaccination. Their coverage is more than 90%. But in the other parts, it is only 30% vaccine is done at the fixed center, while the vaccinator has to go door to door. So it's a community participation which is an essential part of the PHC.
Right.
It should be promoted. That is the way we can get good results.
Dr. Sobia, 2 things we can do.
I think the key is the prevention, and we have to start with prevention if we really want to have universal health coverage with VHC. And the prevention has to start from the school-based trainings, nutrition, vaccination, and just from the grassroots level. Secondly, build up on the frontline workers. So we have lady health workers who are generally giving population control advice or gynecological services, they can be upscaled to screening for diabetes, for hypertension, for obesity, because these are the rising threat of non-communicable diseases. Then better data and digital tools. I think it is the area of digitalization, and without electronic records, it's not possible to make our policies. And finally, I would say proper referral between the primary healthcare hospital and the hospitals. That needs to be smooth and recognized.
Ji. Thank you so much. Dr. Asif, what 2-3 things we can do?
Ji, I think if you really look at the theory, it is very simple. The problem is implementation. That takes time, money, and all that. So I think यहाँ बैठ के we can say कि ये कर लें, वो कर लें, but I'm afraid it's not going to happen. So I'll give you this simple, actually very straightforward principles, especially on the primary healthcare. And this is what I've basically learned from the WHO and working in the field. So you start at the basics. Our model of care is flawed. We need to develop a multidisciplinary, patient-centered, preventive model of care. Now that's very simple to say, but doing it is very, very difficult. So a model of care, we need to come up with a model of care which the private and the public sector agrees on and say, okay, this is what we want. Right now we have multiple models of care, and that's not going to work. Second is training is the key. If you have a system and you put in the current nurses and the doctors to run that system, it's not going to work. So you need a very robust, multidisciplinary, competency-based training programs. So it is task-driven. It's not theory-driven. What you need to do, you need to train on that. So for example, a primary healthcare team, like I mentioned before, needs a doctor, needs a nurse, needs a pharmacist, needs a care manager who manages everything, right? You need a clinic supervisor who does the administrative work. So these are a lot of things that we need to do. So training, I cannot emphasize too much on training.
Okay, thank you.
Second, how do you implement it? Implementation में आपने training दे दी और उनको employee लगा दिया, वो अपनी मर्जी का जो भी करना है. Accountability systems, that has to be there. And उसके बगैर आप quality दे ही नहीं सकते.
Great.
You know,
Thank you so much.
standardized quality of care, you need to audit that, you need to monitor it. If someone is not following it, they have to follow it.
Thank you so
Right?
much. Ji.
Implementation. The other simple things is WHO has actually told us how to do it. So there are 10 operation levers of a primary healthcare center. You can just adopt that and implement it. And they're telling you how to do it.
Sure.
Right?
Sure.
So the solutions are there. We just need to get on
Easy
it.
to implement.
Right.
Ji, Thank you so much, sir. Dr. Javed Saab, just 2-3 things that we can do, and then we'll wrap up this session.
Thank you. I have more thing to offer, obviously, because since I am dealing with the PHC, and mainly all have been touched upon by my senior colleagues. Very importantly, increase budgeting towards PHC, as was mentioned by Dr. Khalid, because to prioritize PHC, the percentage of budget has to be increased. Infrastructure development, obviously, we are still lagging in the infrastructure. We don't have updated infrastructure who cater to the needs of modern the PHC demands. HR strengthening very important. Dr. Asif has mentioned that training is very important, because without strengthened HR, we can't do it, and we have to incentivize. As has been said by Dr. Javed. What PPC has been doing, like we have introduced third allowance at Tharparkar district, which is a very handsome amount, which is equivalent to one additional basic pay, and it's attracting doctors even from Karachi. Quality of care is very important. Continuous adaptation to modern protocols and standards, that's very important. Community engagement, because PHC can't be comprehensive without community outreach and without intervention for behavioral change. It's very important. Referral system was mentioned by Dr. Khalid, very important, because Obviously, PHC can't cater all of the services. So a robust referral system can save so many lives, and it can, evenly shift the balance between primary healthcare and secondary healthcare. Finally, last not but the least, that is digitalization of the service, because without profiling, we can't proceed. Very important in this modern day AI-based world, we have to digitalize
Lovely.
services.
Thank you so much, Ji. So with this, we close our session with these esteemed panelists. And the wonderful part is that they all agree on the similar points that we need to do to achieve the universal health coverage in the primary healthcare SDG goals. With this, we would like to ask if there is any question from the participants, or we have time for one or two.
We have to.
Two questions?
Really sorry. Some questions definitely they would have been there.
Okay.
But
we want to wrap up the question. Okay.
May I request Professor Aftab Mohsin to please join us on the stage? Governor Sindh is on the way.
Okay.
Actually, he has reached. So we would like to distribute the shields, and then you have to.
Can I just thank them?
No, you can thank them. And
आप लोग प्लीज बी स्टे सीटेड या थैंक यू सो मच आबिद साहब अगर आप के फर्दर हमारे गेस्ट और चीफ गेस्ट आर कमिंग सो वी विल जस्ट मॉडिफाई दिस एंड ऑफ द सेशन सर प्लीज हैव अ सीट हियर दिस सेशन एंड आई विल हैंड इट ओवर टू आबिद साहब
Ladies and gentlemen, I would now request Professor Aftab Mohsin, President PSIM, for giving away the shields to our esteemed panelists. I would also request Mr. Zuhair Nasir, CEO, Badar Expo Solutions, and Dr. Abid Abbas Sheikh, Organizing Secretary, Healthcare Expo, to please join him up on the stage. Dr. Zainab Hassan, Professor Javed Akram, Professor Khalid Shafi, Professor Somya Iqtidar, Dr. Asif Imam, and Mr. Javed Ali Jagirani.
It's 2 p.m.
At Badar Expo Solutions, we are committed to connecting people, creating values, and delivering impactful events. Our mission is to make emerging healthcare trends and innovations accessible globally, while fostering meaningful B2B matchmaking opportunities between local and international stakeholders.
हेल्थ एक्सपो एंड कॉन्फ्रेंस लास्ट ईयर हमने शुरू की, इस साल इसका सेकेंड एडिशन है. अगेन इसे एक बहुत बड़ी मैं सक्सेस समझता हूँ कि पहले सेशन के बाद हम दूसरे एडिशन के ऊपर आए.
Your vision and dedication in promoting Pakistan healthcare industry through such high-level platform is really commendable.
Let me start by congratulating Mr. Zuhair from Badar Expos and the spirit behind Abid Abbas Sheikh Saab for arranging such a beautiful conference.
ये सिर्फ एक नुमाइश या एग्जीबिशन नहीं है, ये एक सोच है, ये एक सफ़र है जिसकी बुनियाद डाली जा रही है. और हेल्थ केयर एक ऐसा सब्जेक्ट है कि इसको समझने की और इस पर अमल करने की ज़रूरत है. तो मैं ज़ुहैर नसीर साहब आपको और आपकी टीम को बदर सोल्यूशन को खराज तहसीन पेश करता हूँ.
Assalamu alaikum ji. I'm really grateful to the organizers for having this very important session on patient safety. Something which is very close to the heart of everyone who is concerned with medicine, deals with medicine, either in the form of a professional doctor, a medical professionalist, or regulatory bodies like DRAP, or those who are in the process of making medicines like from the pharmaceutical country. So, very important factor which involves all of us equally. So, patient safety is one thing that we feel, and I personally feel, is not given that much significance and importance in our country as it has been given to anywhere else in the world. So, at times, I myself being a practicing surgeon, I know when I was working at the JPMC General Hospital, or later on I'm working in the private sector now, that patient safety does not come as one thing that we should be taking care of as the first step. And that is what we want our new generation of doctors who are coming up, that they should be aware of that. So a panel which represents almost everyone from physician, Aftab Sahab, from surgeons, to those who are in regulatory bodies, from PharmU, and those also who are from the hospital side, like Nashwa is from the South City Hospital. So let's start. I'll start you, sir, Aftab Sahab. What structure and cognitive factors most commonly contribute to the diagnostic errors that we make? And there are a number of diagnostic errors we all know. And how can healthcare team, not an individual, proactively mitigate them? What do you think? What do you think how it could be done?
I think the first thing to do would be to define diagnostic error for the sake of the public. And diagnostic error means when you cannot make the right diagnosis, or you miss the right diagnosis, or even if a diagnosis is delayed, that is also called a diagnostic error. And if even the diagnosis is correctly made, is made in time, and is not communicated to the patient in time, even that is a diagnostic error. So in US, about 12 million diagnostic errors took place 2 years ago in 1 year. And they were responsible for a number of deaths. Diagnostic errors, they come under the ambit of medical errors. And the medical errors were first highlighted in a report of Institute of Medicine, which was published in 1999. So, I personally believe that these occur because we do not do what Sir William Osler asked the modern day physician to do. And he was a professor at University of Pennsylvania in 1905, beginning of the last century. And he said, listen to your patient. He is telling you the diagnosis. So unfortunately, we are more focused on clinical decision support systems and artificial intelligence, whereas in many prospective studies we know that the correct diagnosis can be made in about 75% cases on history alone, 6 to 7% on examination, and 13-14% on investigations. So if we employ the right history, spend quality time with the patient, examine, and become a thinking doctor. One important thing is, as we become senior, we stop at times to think and do things reflexly. And that contributes to diagnostic errors. Once the diagnosis is incorrect, then it erodes the trust. It jeopardizes the outcome of the patient. It causes extra burden on the cost. Medical errors, sir, are responsible for an additional cost on healthcare of $50 billion per year. So this is all preventable if we start with the right history, spend time with the patient, and if we have systems in place. Unfortunately, when we are overburdened with patients, we do not have systems. So first is the cognitive problem, that the physician herself or himself is at fault. Then are the systems. अब वो हमें कहते हैं कि जी EMR इलेक्ट्रॉनिक मेडिकल रिकॉर्ड होना चाहिए। आप बड़े बड़े ओहदों पर रहे हैं माशाल्लाह, and you have headed so many institutions, and now you are at the helm of the policy making in the province of Sindh and with the status of a minister. So you should know that these doctors, EMR requires time. If you go to US and UK, a doctor is supposed to see only a maximum number of 10 to 12 patients in one day, because it takes 30 minutes to register the patient on EMR. तो एक तरफ एक्सपेक्टेशन है कि EMR हो, दूसरी तरफ नंबर ऑफ पेशेंट ज्यादा है। फिर हम जब मांगते हैं एज अ फिजिशियन सर, वी आस्क फॉर डेटा एंट्री ऑपरेटर, तो वो कहते हैं नहीं ये आपने खुद करना है। तो बड़ी ही एक डायलेमा है। फिर दो चीजें और हैं, विद परमिशन ऑफ द चेयर आई वुड लाइक टू हाईलाइट जो डायग्नोस्टिक एरर में सिग्निफिकेंटली कंट्रीब्यूट करती है। एक है हेल्थ डिस्पैरिटीज, और आपसे ज्यादा कौन अवेयर होगा कि जब मरीज आता है हॉस्पिटल में तो वो लोग जिनको सबसे ज्यादा जरूरत होती है केयर की, दे एंड अप रिसीविंग द लीस्ट केयर। आई विल हाईलाइट फ्यू एग्जांपल। पीपल हु इंजेक्ट ड्रग्स, डॉक्टर्स मोस्ट ऑफ देम लुक डाउन अपॉन देम, ऐसे जैसे वो कोई जुर्म करके आ रहा है। वो तो बेचारा ड्रग एडिक्ट अपनी मर्जी से नहीं हुआ है, वो तो आपकी शफकत और मोहब्बत चाह रहा है। पीपल हु आर लेफ्ट अनअटेंडेड, पीपल हु आर पुअर एंड मार्जिनलाइज्ड, पीपल हु आर मेंटली चैलेंज्ड, पीपल हु आर ओल्ड एंड हु हैव मल्टी मॉर्बिडिटी, ये सारों को ज्यादा जरूरत है। और प्रिजनर्स, लेकिन इनको कम मिलता है। तो एक ये भी वजह है डायग्नोस्टिक एरर्स की और मेडिकल एरर की। और सर एक और वजह वो है ये सिस्टम कोई इंसेंटिवाइज नहीं करता, या कोई अच्छा काम कर रहा है या बुरा काम कर रहा है, वो सब के लिए बराबर है।
डॉक्टर नवीद, कंटिन्यूइंग विद व्हाट आफ्ताब सर ने बताया इन अ वेरी वेरी नाइस elaborative way what errors are. Don't you think, as he has said, that right now we are emphasizing more on the diagnostic tools rather than applying our knowledge of medicine in the form of history taking, examination, which our professors used to emphasize a lot. And they were of the view that, as he has very correctly said, that majority of the diagnoses are made on that. Today, हम या हमारे साथ जो लोग हैं, because of the availability of CT scan, MRI, so many things, the first thing we do is when the patient comes with for example, a headache, MRI karakia. Now taking an easy way out to diagnose, because we have got so much rush, we don't want to examine him properly for that. आप क्या समझते हैं, does it contributing to diagnostic error, and how can it be overcome?
Sir, thank you very much for giving me a chance to collaborate myself on such an important topic. So you are very right, sir. Said a very important sentence in the beginning that listen to the patient, he is telling you the diagnosis. So I personally feel that one factor is the patient's workload, because a doctor has to see a lot of patients in 3 to 4 hours, and the patient expects that the doctor should not only listen to him or her, he should also examine her and him and then prescribe the relevant investigation. But I personally feel, sir, keeping in view all these limitations, they are there, but one link is definitely missing, and that is we do not touch our patient. That sense of touch, like we talk of the sense of touch between the mom and the baby, exactly the same relation exists between the patient and the doctor. This link is missing, and how we can re-establish this link, I don't know, because the patient to doctor number is too much. But I personally believe that this factor should be addressed seriously, and this should not only develop the patient-doctor, strengthen the patient-doctor relation, but it also decrease the workload on our investigations. Like, number one, the patient expects a doctor साहब को test ही लिखा, so doctor writes the whole battery of the investigation, including chemistry and radiology and everything. But if we start doing that, and if we start developing the rapport with the patient in terms of detailed history and clinical examination, and then full explanation to the patient, because once the patient leaves the patient, office of the clinician, he's I don't know, मुझे तो नहीं पता डॉक्टर साहब ने कि मुझे क्या मसला है. So we should properly explain the patient, and it would definitely decrease the workload on our investigation to better investigation. As sir mentioned, I was reading a few days back, because it would also jeopardize the number of patients. It would also jeopardize the patient safety as well, which is our prime topic today. And recently I was reading an article in which it was mentioned that the number of deaths in USA, because USA and UK, they are the icons for us. We read the books written by their doctors, and it counts around 2 lakh a year because of the breach in the patient safety chain. And number two example of UK, the NHS budget rose almost to 40% in the last 1 to 2 years. So I personally believe, sir, highlighting the very true topic of this age. The number of patients is the main cause that our diagnostic battery of investigation is rising, and we are missing the link between the patient and doctor, because we cannot explain to him, we cannot examine to him.
Samad Sahab, ये बताएं कि because you are in digital, which is the latest thing like AI and other things the companies, do you have any solution for the problem that has been raised for overcoming these diagnostic errors? Do you have that? Not only relying upon the diagnostic tool, because once the tool goes wrong, the whole management will go wrong. So, do you think that the recent trends that you are just talking about, bringing up together, can they be of any support in overcoming this decision making of a diagnostic tool not to go wrong?
Assalamu alaikum. Thank you so much, sir. First of all, we at Digitrends currently working on the AI solutions which we think can make a difference in patient safety. I will give you, for example, which I think is relevant, how AI and IT can make a big impact on patient safety. First of all, we are going to integrate it with our EMR solution. So currently in the conventional EMR, if doctor enter the wrong medicine, or if any medicine which is not suitable for the patient, he has the allergies or some kind of histories, doctor cannot go through all the EMR details every time, and he can enter wrongly some medicine which may affect the health of the patient. Our AI system can be integrated with the EMR, and it can, in the real time, stop the doctor that do not enter that kind of medication that can be harmful for the patient. This is the one example, and there are many other features which can be very helpful when AI will be integrated into the current AMR solution. The second example would be, we are currently working on the world first FDA-approved wearable ECG device. So currently what is happening, when the device is taking the ECG of the patient, it is transmitting the data to the mobile application, and that mobile application submitting that data to the doctor, who is actually manually reading the ECG, and then he is diagnosing and prescribing the medication over his whatever he sees over his diagnosis. Now, if we integrate AI into that in between, where doctor is currently diagnosing or checking the ECG, the AI system can do this automatically, and he can suggest, the AI can suggest either the patient needs immediate attention of the doctor, so it can send the ambulance, or through telemedicine, doctor can connect to the patient directly. So if we will integrate AI agents into this hardware monitoring system, healthcare hardware monitoring system with the patient and doctor, that AI can do the job of the doctor, the initial job of the doctor. So it can be make great impact as well. The third thing is that differential diagnosis tool. We are partnered with the leading differential diagnosis tools such as Visual DX. So we integrated that Visual Diagnosis. We launched that differential diagnosis tool here in Pakistan. we saw a very good adaptation on AI on that tool. If you take a picture of your skin region, the AI image recognition system can recognize either it's psoriasis or eczema through the thousands of images which is already stored in the database of the AI. And doctor who may know, maybe he cannot diagnose that this is the early stage of psoriasis, AI can detect it in a very early stage. So these are the 3-4 examples which I think, and this is already happening in the world. AI has been integrated. The question is, we are not only trying to implement and integrate these solutions currently within this Pakistan market and in Saudi and in Dubai. We are also taking care how the AI governance and how AI compliances can be a part of it. So it can be implemented. Again, it's related to patient safety also. So I think AI will make a great impact, inshallah.
Thank you. Dr. Mema, my question to you, because you're also associated with the pharmaceutical, what prescribing safeguards are there for effective avoiding any prescribing liquidity or anything that can be a wrong prescription because you're associated with the pharmaceutical? What safeguard the pharmaceutical has done to them? For example, I can give you a number of medicines with a similar name, similar appearance. In cases of an emergency, sometimes the does pick up the wrong one, and it may be illegal for the patient. So, what are the safeguards that the pharmaceuticals taking in order to avoid these prescribing?
All right. Thank you so much. My name is Umema. Thank you for inviting. I'm representing a pharmaceutical company here, but I also hold a position for a primary healthcare setup here in Karachi. So I have kind of an ambit or a cap of both, say from a pharmaceutical perspective and from the hospital end as well. And there have been a lot of solutions that AI ki baat kari, and there are a lot of integrations. And same goes when it comes to patient safety, and we talk about what systems can be implemented in pharmaceutical companies. But before I can actually talk about what should be done, I'll be talking about a patient safety culture. And there is a small presentation, if you may all allow me to give a small presentation of the magnitude of patient safety which we are talking about, especially here in Pakistan. So, sir, if you may allow, I'll just give a brief presentation. It's hardly of 10, 11 slides.
So we can just discuss that now. We can give us a brief description about that.
I'm sorry?
We are running short of time, so...
Okay. All right. So I'll just make it very precise. See, for me, when it comes to ADR or pharmacovigilance, or we talk about reporting system, the first thing which has to come is to start reporting. We do not hold here a culture of reporting. DRAP already has established systems in which the healthcare providers and the people who are in the pharmaceutical companies are encouraged to report any ADR which is reported. And I'm talking about the drug reporting errors. I'm not talking about the medical errors, jaise Dr. Saab ne initially kaha ki that also comes under the ambit of medical error. But unless and until we do not know what is being reported and what are the root causes of it, how are we going to actually establish systems in our areas to counter that? And I'm sorry, I was not able to listen to your specific questions regarding pharmacovigilance.
Regarding the drug use, for example, recently, DRAP has withdrawn a syrup because it was causing a lot of complications. Many medicines are withdrawn. So both pharmaceutical industry is taking care of avoiding those errors to take place when you are manufacturing a medicine. What are the protocols that you follow? Are there any protocols?
Yes, definitely. See, pharmaceutical companies, especially in Pakistan, I would consider this is the most regulated industry in Pakistan. And it has federal regulations applying to it as well as the provincial ones. So there are systems established. Say, for example, I'd give, an example of LASA, which is called as the lookalike enzyme villi, which is the major, one of the major causes of wrong administration or wrong prescribing. And there is a whole system established by pharmaceutical companies, especially the MNCs as well as the local pharmaceutical companies, they have established systems in which they do have protocols, and especially with the integration of AI into such systems, we are able to check that. And similarly goes with the names. But unfortunately, I would refer to the recent cases of Avastin, as we all are well aware. The case of ceftriaxone, we already know that. But these were malpractices of administration rather than something which was falling under the pharmaceutical category. So the indications are, of course, devised.
Thank you very much. Nashwa, you are related to a hospital, a major hospital in the city. So what do you think in a hospital? We all know there are so many cases reported, so many errors take place. We wait time and time to the patient. Patients have lost life. So do you think what are the major protocols that could be applied, or what are the systems that need to be in place in order to avoid all that what is unfortunately happening if patients are being mistreated or being misdiagnosed or whatever you say, which is harmful to the patient whenever they come to the hospital? Any protocols or systems that you think are there, or you will suggest them to be applied?
Ji, Assalamualaikum. Thank you, sir, for having us. Thank you for having us. So I work very closely with a lot of workflows with different kinds of healthcare providers, be them physicians or nurses. Now, in terms of reducing harm, there are different components to how you can reduce harm based on who the provider is. जैसे हमने आज की discussion में देखा है, the physician's perspective or the surgeon's perspective is very unique and different. They have different goals for the patient, be it their assessment, their diagnostics, the treatment plan. That is a vision which is dedicated to the physician. Where safety falls in, where measures fall in, where systems fall in to reduce harm in that pathway is separate. That is something that is addressed separately, that has different patterns, different safety measures. If we're talking about surgery, for example, something which may seem like a very simple process, but starting from when the moment the patient arrives in your clinic, what is being communicated, what is being documented, what is going on the record, what does the patient understand from everything the surgeon is saying? And in the event of a harm happening, was that harm pre-warned, pre-informed to the patient? Was it uninformed to the patient? What are accountability measures in place for the surgeon or for the providers? So, surgeons, for example, nursing is a completely different game. Nursing ka role is absolutely separate. They are more involved with the hands-on care of the patient in a time which is vaster than it is for the physician. How to reduce patient falls, how to prevent the patient from getting harm from regular activities while they're in the hospital setting, during mobilization, during eating, to prevent aspiration, for example, to prevent medication errors. What is the process of the medication cycle? Uske humne kaun se metrics, accountability tools rakhe to make sure medication is being given safely.
Also, being a physician, there are a number of times we are prescribing a medicine. A patient has got a problem. He says, for example, full factor deficiency, I have got epilepsy. And when we are prescribing a medicine for that, not for that, for other reasons, we at times do not know whether this medicine will be harmful to that or is contraindicated to that. So at times we miss, because no doctor can have knowledge about every disease and what medicines they are indicated. Do you think the use of e-prescription could be effective in that, or still the use of our own intelligence in that will be more effective?
I think, sir, you have rightly pointed out electronic medical record or e-prescription can help reduce it, magar it cannot eliminate it. Healthcare industry is supposed to be an industry which is far less regulated than many other industries like flying industry. People who are flying jets and airlines, they are far more meticulous in their approach, whereas the number of people suffering at the hands of medical error is far more. In USA alone, medical errors have become the third leading cause of death of them, there are 250,000 every year, half of them are preventable. And sir, 250,000 makes it about 680 per day. That is like 1.5 jumbo jet going down every day. And look at the time, look at the method, look at the money that is being spent on airline safety compared to healthcare safety in our profession. So something we are doing is absolutely wrong, and it requires a paradigm shift.
So what do you suggest? Like, as we have very correctly said, there are a number of prescribing errors that we are making. Even the most senior ones make an error in prescription, and they miss on the history of the patient because EMR is very good, it's a new thing. But practically speaking, as we have been working in a government sector hospital, the prescription when you write a government sector hospital in an OPD with 300 patients standing and you have to pass within 3 to 4 hours, it's not possible to go for an EMR for each one of them. Either it should be a limited number of patients that you have seen, but you have seen an uncounted number of patients. उस कंडीशन के अंदर what do you suggest, what protocol or what safety measures could be undertaken कि आप either it should be at the end of the prescribing doctor or the pharmacy which is issuing should take care of that when the pharmaceutical after prescription जाए that this drug should not be given to this patient or the dosage is not correct. What do you think? How could it be counteracted?
I think, sir, you have highlighted the issue in your own question that it cannot be anyone working in isolation. What we are doing right now is working in silos. Physician working as a physician, pharmacist working there. EMR, I don't think is going to be the solution in Pakistan. There are two things. I am an old school. I believe that if you spend quality time with the patient, that not only builds trust, it also ensures patient safety and it also ensures quality care to the patient. But at the same time, we have to think differently. The money cannot go to the armed forces of Pakistan and our patients deprived of their due rights. ये कहाँ पर होता है कि 1% GDP से भी कम हम एजुकेशन और 1% से कम हेल्थ पे खर्च कर रहे हैं. This thing will have to change if you want to change or contribute. अमेरिका में वो कहते हैं कि हम 2,50,000 लोग हमारे मरते हैं हर साल और वो कहते हैं कि 3 मिलियन लोग मरते हैं दुनिया में हर साल. पाकिस्तान में तो रिपोर्ट ही नहीं होती. इंडिया में 54 million medical errors take place every year, which is among us. So हमारे तो वो figures ही नहीं है. So we have to bring in more money, we have to bring in more resources. और वो पाकिस्तान के कहाँ से आएंगे? डेट सर्विसिंग से आएंगे, आर्म फोर्सेस से लेंगे. ये अभी बात हो रही थी सर कि प्राइमरी हेल्थ केयर पे पैसा नहीं लगाते और इंडस को 10 बिलियन दे दिया. भाई इंडस को 10 नहीं 20 चाहिए, मगर ये नहीं है कि वो ये समझते हैं कि इंडस से लेके नहीं लगाया जा सकता. इंडस को पहले ही ज्यादा चाहिए, आपको मजीद पैसा चाहिए और उसको लाना पड़ेगा in order to improve the health. Or EMR is not the solution, sir.
So what we conclude is that though these gadgets are very good, the EMR or the digitalization in Africa, but it is not this case. You can have a blanket thing from the US coming to Pakistan and make it. We have to cut it according to our own needs and our own requirements and our own problems that we have. सबसे बड़ा issue ये है कि you don't have that much of resources available. जैसे कि रोबोटिक के बाद सिंध में एक बड़ा हंगामा हुआ 2000 whether to buy a robot or not to buy a robot, costing billions of rupees. Whether that should be spent on a robot to be bought or that should be spent on primary health care. Because tertiary health care is given more emphasis upon in every part of Pakistan rather than the primary health care. जबकि दुनिया भर में मतलब प्राइमरी हेल्थ केयर ज़्यादा करें ताकि आपको पेशेंट ही ना है. क्लीन वाटर नहीं है आपके पास, इम्यूनाइजेशन की कमी है, and they all better. मैं नवीद साहब आपसे पूछूंगा, being a surgeon, we make a lot of errors. I am a surgeon myself. What checklist, team communication strategies, or data tools you will suggest that can avoid those errors that we make during our surgery?
Sir, so this is a very important topic, and I think this is all we being clinicians are meant for. The patient safety first. And these all checklists, they are meant for this purpose. There are many checklists, sir. First is a WHO checklist, and the second is the SURPASS checklist. Surgical patients safety factors. But sir, I personally believe before we go to the fancy checklist, we need to educate our healthcare providers. And actually, sir, we start with the top-down approach: consultants, and then senior residents, and then junior residents, and actually. The main stakeholders, in my opinion, they are the nursing staff. You may agree or not that most of the time spent with the patient is by the nursing staff. So checklists are there, sir. Definitely, like WHO checklist. WHO checklist, sir, is basically is meant for mainly in the operating room, before induction and before NCM and before the patient leaves the operating room. It mainly encompasses all that horizon while the patient is inside the operating room. Actually, sir, the safety starts right from the clinic of the clinician. When the patient visits the clinic of the clinician, the safety measures need to be adapted. In the case of preoperative care and then followed by intraoperative and then postoperative care. And the whole scenario is encompassed by the one term that is called these days as perioperative care. So in my opinion, in preoperative care, we should emphasize on detailed history. Actually, sir, I would conclude in one line: go back to the basics. Actually, sir, we have left the basics, and we have done like sir said, like electronic medical records and like EMS system and EMR system, everything. It looks very fancy. It fantasizes someone. We are like advancing in every field, but we have no money with us. So we will have to go back to the basics. We will need to take the detailed history and examine the patient and then assess the comorbids and do a detailed and good pre-anesthesia assessment before the patient is subjected to surgery. And likewise, while the patient is in the ward the night before the surgery, I personally believe no doctor goes to the patient to document the things like which side is to be operated upon, whether it is right side or left side, where the stoma is supposed to be formed. This is done by nursing staff. Right? And the consent form is put in front of the patient. Please यहाँ sign कर दें. What is written in that consent form? Neither the staff nor the patient and nor the tenders don't know anything. So, sir, in my opinion, these checklists, they are very good. But after once we have done our homework, we have taught our basic stakeholders in the wards, in the hospitals, in the OPD, and then, sir, in the operating room, mainly WHO checklist. Definitely, if it is emphasized in true letter and spirit, it can avoid so many avoidable medical accidents, right, sir? And then, obviously, post-operatively, in the theater, the main stakeholders are an anesthetist and then followed by the surgeon. And then post-operatively, again, the surgeon operates and he endorses the notes, and the whole night patient spends with the nursing staff. And the nursing staff, the ratio must be 60:1 or maybe 60:2. And I think, sir, basic homework needs to be improved.
At Badar Expo Solutions, we are committed to connecting people, creating values, and delivering impactful events. Our mission is to make emerging healthcare trends and innovations accessible globally, while fostering meaningful B2B matchmaking opportunities between local and international stakeholders.
हेल्थ केयर एक्सपॉइंट कॉन्फ्रेंस लास्ट ईयर हमने शुरू की, इस साल इसका सेकेंड एडिशन है। अगेन इसे एक बहुत बड़ी मैं सक्सेस समझता हूँ कि पहले सेशन के बाद हम दूसरे एडिशन के ऊपर आए।
Your vision and dedication in promoting Pakistan healthcare industry through such high-level platform is really commendable.
Let me start by congratulating Mr. Zohair from Badar Expos and the spirit behind Abid Abbas Sheikh Saab for arranging such a beautiful conference.
ये सिर्फ एक नुमाइश या एग्जीबिशन नहीं है, ये एक सोच है, ये एक सफ़र है जिसकी बुनियाद डाली जा रही है। तो मैं ज़ोहैर नसीर साहब आपको और आपकी टीम को बदर सॉल्यूशन को खराज तहसीन पेश करता हूँ।
हमने पिछली मरतबा एक टॉपिक के ऊपर पैनल डिस्कशन किया था। इस मरतबा हर स्पीकर को हमने अलग अलग टॉपिक दिया है, तो उससे इन मॉडरेटर को भी और पैनलिस्ट और ऑडियंस को भी ज़्यादा फ़ायदा होगा। आई एम थैंकफुल टू ऑल द कोलैबोरेटर्स, स्पेशली बदर एक्सपो सॉल्यूशंस, उसका हर डिपार्टमेंट। आप जो ये पूरा सेटअप देख रहे हैं, ये सेटअप जो है ये मुमकिन नहीं था अगर बदर एक्सपो सॉल्यूशंस की मुझे पूरी सपोर्ट मौजूद नहीं होती। तो आई एम रियली थैंकफुल टू यू ज़ोहैर साहब।
बहुत सारे पैनलिस्ट्स और एक्सपर्ट्स के साथ नेटवर्किंग का मौका मिला। एक बहुत ही वंडरफुल इंटरैक्टिव एकेडमिक लर्निंग एक्सपीरियंस था जिसमें हमने हेल्थ केयर सॉल्यूशंस की बात की। और बदर एक्सपो हेल्थ केयर सॉल्यूशंस एक ऐसा प्लेटफॉर्म है जहां पे जो लीडिंग एक्सपर्ट्स हैं वो नेशनल लेवल की पॉलिसी की रिकमेंडेशंस दे सकते हैं।
बदर एक्सपो को सबसे पहले मुबारकबाद है ज़ोहैर नसीर साहब को, उनकी टीम को, कि उन्होंने इतना ज़बरदस्त प्रोग्राम विच इज़ सो मच नीडेड फॉर द हेल्थ केयर ऑफ पाकिस्तान ऑर्गेनाइज़ किया। टोटल सिंध में 17 डेंटल कॉलेजेस हैं। तो अमेजिंग बात यह है कि 17 की 17 डेंटल कॉलेजेस ने पार्टिसिपेट किया, उनके बच्चों ने पार्टिसिपेट किया, उनकी फैकल्टी ने पार्टिसिपेट किया। इन एडिशन लॉट्स ऑफ सीनियर डेंटिस्ट केम टू फॉर दिस इवेंट। और ये इवेंट मैं देखता हूँ कि फ्यूचर में एक आइकॉन की हैसियत हासिल कर लेगा डेंटिस्ट्री में इंशाअल्लाह।
इतने सारे लोगों को एक साथ हैंडल करना और फ्लॉलेसली उसको ऑर्गेनाइज करना, लाइट्स, कैमरा, स्पीकर्स, जजेस, कंटेंट वाज वेरी 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 नाइस। अपार्ट फ्रॉम दैट आई थिंक ये इस किस्म के इवेंट्स होने चाहिए। इट्स नॉट जस्ट गुड फॉर द ओवरऑल डेंटल कम्युनिटी एंड ऑल्सो फॉर द मेडिकल कम्युनिटी एंड द कंट्री एट लार्ज।
ये इस तरह के इवेंट स्टूडेंट्स के लिए एक बहुत लैंडमार्क समझे एक इवेंट की हैसियत रखते हैं, बिकॉज ऐसे मौक़ों के ऊपर स्टूडेंट को न सिर्फ ये कि अपनी नॉलेज बल्कि अपना टैलेंट जो कि उनकी तालीम के अलावा भी होता है उसको डिस्प्ले या शोकेस करने का मौका मिलता है। तो मैं एक दफ़ा फिर तमाम ऑर्गेनाइजर्स, तमाम स्पॉन्सर्स को बहुत मुबारकबाद देता हूँ कि एक बेहतरीन इवेंट ऑर्गेनाइज़ किया और इंशाल्लाह अगले साल पर इससे बेहतर इसी तरह के एक इवेंट में हम दोबारा मुलाकात करेंगे। थैंक यू। अस्सलाम वालेकुम।
डेंटिस्ट्री को पिछले एडिशन की तरह इस दफ़ा भी इनवाइट किया कि हम उसका पार्ट बने, और हमारे कॉलेज से उन्होंने कहा कि हम इसको ऑर्गेनाइज़ करें। तो हमने डेंटिस्ट्री का प्रोग्राम ऑर्गेनाइज़ किया उनके लिए। 3 दिन का प्रोग्राम था डेंटिस्ट्री का।
हेल्थ केयर एक्सपो का सेकेंड एडिशन जो कि एक्सपो सेंटर कराची में मुनक़िद हुआ और 3 डेज़ की ये कॉन्फ्रेंस थी। इसमें तीनों दिन हमारे साइंटिफिक सेशंस रहे, इंडस्ट्री एक्सपर्ट्स से आए, प्रोफेशनल एक्सपर्ट्स आए और एजुकेशनल सीरीज़ थी एक लेक्चर्स की जो कि तीनों दिन रही.
Alhamdulillah, we had a great turnout and it was more than what we expected. So Alhamdulillah for everything and thank you everyone who attended our program. Inshallah for next time इसे बेहतर करेंगे और उम्मीद है कि आप सब हमें join करेंगे. Thank you so much.
Thank you very much Badar Expo for having me or giving me a chance and my team to bring a change into this aesthetical industry.
एक्सपो जो हो रहा है जी वो बदर एक्सपो ने करवाया है और बहुत सारी उनको मुबारकबाद क्योंकि बड़ा अच्छा इवेंट है और बड़ा अच्छा फुटफॉल है. लोग आके यहाँ पर अपने हेल्थ सोल्यूशंस ले रहे हैं. सो उम्मीद करता हूँ कि इस तरह से करते रहेंगे और आगे भी ये काम अच्छा चलता रहेगा.
वेरी ऑर्गेनाइज्ड, वेरी वेल ऑर्गेनाइज्ड इनफैक्ट. और हेल्थ केयर की जितनी सर्विसेज मैं यहाँ देख रहा हूँ, जितने लोग यहाँ देख रहा हूँ, फार्मास्यूटिकल कंपनीज आर हेयर, हॉस्पिटल्स आर हेयर एंड ऑफ कोर्स सिंध का अपना जो SIHS है दैट्स हेयर और बहुत सारी और चीज़ें हैं. सो जस्ट अ वंडरफुल एक्सपीरियंस ओवरऑल. बहुत होलसम एक्सपीरियंस है और आपको आके एहसास होता है कि पाकिस्तान में बहुत काम हो रहा है. स्पेशली द पीपल हु हैव ऑर्गेनाइज्ड दिस. बदर, थैंक यू सो वेरी मच. बहुत बहुत शुक्रिया फॉर इनवाइटिंग मी.
Crowd was amazing. We had all the honorable guests with us. Our guest of honors, they were dignitaries and they were council generals and very senior doctors and professors as well. So I had an amazing time and the ambience of the event is really nice and wish you best of luck Badar Expo.
हम यहाँ मौजूद है एक्सपो में जिसको आज यहाँ सजाया है ज़ुहैर नसीर. तो आप जरूर विजिट कीजिए, आपके बहुत सारे सोल्यूशंस का यहाँ मिलेंगे.
बदर एक्सपो की तरफ से जो है एक अच्छा हमें प्लेटफॉर्म मिला हुआ है IEEE फेयर का, जिसके अंदर हम लोग अपने डिफरेंट प्रोडक्ट्स को जो है शोकेस करते हैं.
बदर एक्सपो ने हमें एक प्लेटफॉर्म दिया, वो हमें काफ़ी सपोर्ट भी करती है और यहाँ पे डिफरेंट कंपनीज को भी उसने काफ़ी सपोर्ट किया है.
like to thank the dignitaries and all the guests, the sponsors, the exhibitors who have been with us through the years and have made this event possible.
It is a great opportunity for the investors and even the dealers and the distributors to participate and engage in this seminar, and I further request the management of Badar Expo to continue these seminars for the general awareness of the people.
At Badar Expo Solutions, we are committed to connecting people, creating values, and delivering impactful events. Our mission is to make emerging healthcare trends and innovations accessible globally, while fostering meaningful B2B matchmaking opportunities between local and international stakeholders.
हेल्थ एक्सपोइंट कॉन्फ्रेंस लास्ट ईयर हमने शुरू की, इस साल इसका सेकेंड एडिशन है. अगेन इसे एक बहुत बड़ी मैं सक्सेस समझता हूँ कि पहले सेशन के बाद हम दूसरे एडिशन के ऊपर आए.
Your vision and dedication in promoting Pakistan healthcare industry through such high-level platform is really commendable.
Let me start by congratulating Mr. Zuhair from Badar Expos and the spirit behind Abid Abbas Sheikh Saab for arranging such a beautiful conference.
ये सिर्फ एक नुमाइश या एग्जीबिशन नहीं है, ये एक सोच है, ये एक सफ़र है जिसकी बुनियाद डाली जा रही है. और हेल्थ केयर एक ऐसा सब्जेक्ट है कि इसको समझने की और इस पर अमल करने की ज़रूरत है. तो मैं ज़ुहैर नसीर साहब आपको और आपकी टीम को बदर सॉल्यूशन को खराज तहसीन पेश करता हूँ.
इल्म में भी सुरूर है, लेकिन ये वो जन्नत है जिसमें हूर नहीं। शायर मशरिक अल्लामा इकबाल। बुरा समझूं है मुझसे तो ऐसा हो नहीं सकता कि मैं खुद भी तो हूं इकबाल अपने नुक्ता चीनों में। शायर मशरिक अल्लामा इकबाल।
It's 3 p.m.
अस्सलाम वालेकुम। 13th एडिशन ऑफ IEEE फेयर 2024 के एक्सपो से एक्सपोजर में नसीम राजपूत एक्सपो सेंटर कराची से अपने तमाम व्यूअर्स को खुशामदीद कहता है। थैंक यू वेरी मच तमाम हमारे स्पॉन्सर्स का कि जिन्होंने हमारे इस सुपर आई को, या मैं कह सकता हूँ कि हमारे एक्सपो से एक्सपोजर को स्पॉन्सर किया, जिसमें अगर मैं देखता हूँ तो SMS इंटरप्राइजेज, डाइची लाइटिंग, शेख विलायत अहमद एंड सन्स, ग्लोबल लाइटिंग एंड डेल्टा पावर, ऑल द स्पॉन्सर्स, थैंक यू वेरी मच। मकसद एक ही दिखाई देता है कि पाकिस्तान की मईशत की तरक्की में हम सब मिलके क्या रोल प्ले कर सकते हैं। और अगर मैं अपने इलेक्ट्रॉनिक और इलेक्ट्रिकल सेक्टर की बात कर लूँ तो इस वक्त लोगों को रोज़गार देने के हवाले से, हमारी मईशत का पहिया चलाने के हवाले से बड़ा इम्पॉर्टेंट रोल प्ले कर रहा है। हम मुख्तलिफ़ सेक्टर्स को देखते हैं, कभी हम सुनते हैं कि जो है वो हमारी जो कंस्ट्रक्शन की फील्ड है वो थोड़ी सी डाउन हो गई है, कभी हम सुनते हैं कि जो हमारी जो ज़राअत है उसको बेहतर करने की कोशिश की जा रही है। लेकिन ये एक सेक्टर ऐसा है कि जो सस्टेन किया हुआ है अपनी कोशिशों से, और इसमें हमने मज़ीद इजाफ़ा ही देखा है, इसमें कमी नहीं देखी है। इसके बावजूद कि इनको पावर सेक्टर से लेके बहुत सारे प्रॉब्लम्स हैं, लेकिन हमने सस्टेनेबिलिटी देखी, हमने ये देखा कि ये कंपनियां ग्रो कर रही हैं। अगर आज हम 13th एडिशन में बैठे हुए तो 6 हॉल के अंदर ये IEEE फेयर 2024 जारी है, और कंपनीज़ की तादाद में भी बहुत ज़्यादा इजाफा हुआ है। माजी में ये 2 से 3 हॉल्स में हुआ करता था। इसका मकसद है कि हमारी इंडस्ट्री ग्रो ज़रूर कर रही है, लेकिन इतनी प्रॉब्लम्स में ग्रो कर रही है। हमारा बच्चा जो इलेक्ट्रिक या इलेक्ट्रॉनिक इंजीनियर आ रहा है उसको फ्यूचर उस तरह दिखाई नहीं दे रहा, और उसके जहन में एक ख्वाब बस गया है कि मैंने मुल्क से बाहर जाना है, मैंने मुल्क से बाहर जाना है। हालांकि ये सब लोग अपनी बिसात के मुताबिक हर मुमकिन कोशिशें कर रहे हैं। इनकी कोशिशों की डायरेक्शन क्या है, ये जानने की कोशिश करेंगे आज के हमारे इस स्पेशल एपिसोड में, जिसका मकसद वी फोकस ऑन द इंटरसेक्शन ऑफ सस्टेनेबिलिटी, टेक्नोलॉजी एंड इलेक्ट्रॉनिक्स। इस पर आज हम बात करने की कोशिश करेंगे। मेरे साथ बड़ी इंपॉर्टेंट शख्सियात गुफ्तगू के लिए मौजूद हैं। मिस्टर मोहम्मद अली नसीर, GM सस्टेनेबिलिटी कैपिटल एंड लाहौर स्मार्ट सिटी, और GM सस्टेनेबिलिटी आपने पहली मरतबा सुना होगा, ये भी हम इनसे जानने की कोशिश करेंगे। थैंक यू वेरी मच मोहम्मद अली नसीर साहब। उनके बराबर में तशरीफ़ रखते हैं ये हमारी कराची टेप बॉल प्रीमियर लीग, जो बदर एक्सपो सॉल्यूशंस का अपना एक ब्रेन चाइल्ड है, उसके भी स्पॉन्सर होते हैं हमारे बहुत ही अच्छे दोस्त मिस्टर शमीम अहमद जुमलाना। थैंक यू वेरी मच शमीम भाई, आपका बहुत बहुत शुक्रिया। वंस अगेन हम लोग जुड़े हैं बदर एक्सपो सॉल्यूशंस के इस प्लेटफॉर्म पे, IEEE के प्लेटफॉर्म पे, और उनके साथ तशरीफ़ रखते हैं मिस्टर सैयद अदनान मुईद, और ये इंडस्ट्री लिंक के हेड ऑफ प्रोजेक्ट हैं। थैंक यू वेरी मच सर। इंडस्ट्री लिंक के हेड ऑफ प्रोजेक्ट हैं। तो बज़ाहिर मैं स्पोर्ट्स का आदमी, थोड़ा तो मार्जिन आपको मुझे देना ही पड़ेगा यहाँ पर। अली भाई, आपसे हम अब बातचीत का आगाज़ कर सकते हैं। GM सस्टेनेबिलिटी ये ख़ुद एक बड़ी डिफरेंट चीज़ है। अच्छा, कैपिटल एंड लाहौर स्मार्ट सिटी का हमने बहुत नाम सुना है, आप ज़बरदस्त किस्म का वहाँ काम करें, पूरा शहर आबाद करने के लिए जा रहे हैं आप वहाँ पर। ज़रा इलेक्ट्रिसिटी और इलेक्ट्रॉनिक्स से तो आपका एक वास्ता चोरी दामन का साथ है सर, जो आप डेवलप करेंगे इनके बगैर तो कर ही नहीं सकते। शमीम भाई नहीं हुए तो काम नहीं होगा, ये तो बहुत ज़रूरी दिखाई देता है। सस्टेनेबिलिटी थोड़ा सा मुझे बताइएगा कि आजकल सस्टेन करना वैसे ही दुश्वार हुआ है।
बहुत शुक्रिया सर फॉर हैविंग मी। सस्टेनेबिलिटी मैं बहुत आसान अल्फाज में कोशिश करता हूँ डिफ़ाइन करने की। सस्टेनेबिलिटी 3 एस्पेक्ट्स के इर्द गिर्द घूमता है और वो है सोशल, एनवायरमेंटल एंड इकोनॉमिक। किसी भी इंडिविजुअल को ये 3 चीज़ें चाहिए होती हैं सस्टेन करने के लिए। सोशल में हेल्थ एंड एजुकेशन आता है, इकोनॉमिक में वो एवेन्यूज़ आते हैं जहाँ से वो अपनी इनकम जनरेट करता है, और एनवायरनमेंट में हेल्दी एनवायरनमेंट आता है, क्लीन एयर आती है, लेस पॉपुलेटेड एनवायरनमेंट आता है, चाहे इंडोर हो या आउटडोर हो। तो किसी भी हाउसिंग प्रोजेक्ट को अगर ये तीनों एस्पेक्ट को मैनेज कर रहा है, या सिटीज़ या गवर्नमेंट, और उसको मेंटेन रखेगा तो वो सस्टेनेबिलिटी या सस्टेनेबल हाउसिंग प्रोजेक्ट कहलाएगा। पाकिस्तान में we take pride in stating that we are the only one in Pakistan who has developed, not developing, who has developed sustainable cities covering all these 3 aspects: social, environmental and economic. तीनों चीज़ें, तीनों सेगमेंट को हमने एड्रेस किया। मैं आपको छोटी सी एग्जांपल दे देता हूँ। हमारे पास ऑपरेशनल 50 बेड हॉस्पिटल है अभी हमारे
अंदर है।
जी
ऑपरेशनल।
जी ऑपरेशन। हमारे अभी रेजिडेंट्स 100 भी नहीं है, 100 फैमिलीज भी नहीं है। हॉस्पिटल ऑपरेशनल है। ऑन टॉप ऑफ दैट मेरे पास एक ऑपरेशनल रिहेबिलिटेशन सेंटर है, ओनली 1 स्मार्ट रिहेबिलिटेशन प्रोजेक्ट ऑफ पाकिस्तान, जिसके अंदर एक हम ऐसी मशीन बाहर से इंपोर्ट की जो आर्टिफिशियल लिगामेंट्स बनाती है। पाकिस्तान में ये किसी के पास नहीं, और ये ऑपरेशनल है
वहीं पर ही।
जी हाँ, ये ऑपरेशनल है। हमारा सिस्टम स्टेम स्कूल सिस्टम ऑपरेशनल है। ऑन टॉप ऑफ दैट वी टेक प्राइड, जो मैं आपको बता रहा था पहले भी, कि हमारे पास सिलिकॉन विलेज है। सिलिकॉन विलेज यानी कि IT टेक ड्रिवन एक डिस्ट्रिक्ट है, और ऑल्दो पूरी सोसाइटी टेक ड्रिवन है, लेकिन ये डेडिकेटेड टेक ड्रिवन एक डिस्ट्रिक्ट है पूरा, जो कि एज़ पर स्पेशल टेक्नोलॉजी जोन अथॉरिटी हमें 30 एकड़ तक रखना था और हमें लाइसेंस मिल जाता। हमने 300 एकड़ रखा है, और अब अल्हम्दुलिल्लाह हमारे पास स्पेशल टेक्नोलॉजी जोन अथॉरिटी है। अब बैक टू योर क्वेश्चन कि ये मैं एक डिफरेंट ये डेजिग्नेशन क्यों है, ये वाकई ही रियल एस्टेट डेवलपर के पास
सुना नहीं मैंने।
जी हाँ, रियल एस्टेट डेवलपर का तो बहुत दूर की बात, जो मल्टीनेशनल ऑर्गेनाइजेशंस हैं, जो लोकल कॉर्पोरेट्स हैं, उनमें ये सेगमेंट भी अभी प्रवेल नहीं करता। हमने अभी देखा है कुछ मल्टीनेशनल काम कर रही हैं, और वो है नेस्ले है, कोक है, इसके अलावा हम नहीं सुन पाए।
वहाँ पर है ये सस्टेनेबिलिटी?
जी वहाँ पे है, और लेकिन वो है सोशल रिस्पॉन्सिबिलिटी की सेगमेंट के अंदर। फॉर एग्जांपल प्लास्टिक को वो रिसाइकिल करके गिलगित बल्तिस्तान में प्लास्टिक के बेंच बना रहे हैं, या प्लास्टिक की टाइल्स बना रहे हैं, कुछ इस तरह है। लेकिन हम पहले रियल एस्टेट डेवलपर हैं इन पाकिस्तान, नसीम भाई, जो कि सस्टेनेबिलिटी के प्रिंसिपल्स के ऊपर प्लान हुआ है और डेवलप हुआ है और इम्प्लीमेंट हुआ है। और इसीलिए इस कंपनी में एक स्पेशल डेडिकेटेड डिपार्टमेंट है सस्टेनेबिलिटी, जो इंश्योर करता है कि हम अपने ऑपरेशंस को कैसे सस्टेन रख सकते हैं थ्रू आउट द लाइफ।
सारे ऑपरेशंस पर आप ही लीड करते हैं?
सारे ऑपरेशन की सस्टेनेबिलिटी सेगमेंट
आप करते हैं?
जी हाँ।
फॉर सस्टेन करेगा तो फिर वही
देखिए नसीम भाई, मैं आपको एक छोटी सी और मैं ऐड कर दूं। सस्टेनेबल डेवलपमेंट हमें ये कहती है कि सस्टेनेबल डेवलपमेंट इज द डेवलपमेंट दैट फुलफिल द नीड्स ऑफ द प्रेजेंट जनरेशन without compromising the ability of future generation to meet their needs. Means कि मैं अगली जनरेशन का वाटर अभी ना यूज़ कर जाऊँ, अपनी क्लीन एयर इसी जनरेशन को ना यूज़ कर जाऊँ, जितनी एनर्जी कंजम्पशन है वो मैं ही ना यूज़ कर जाऊँ कि अगली जनरेशन के लिए कुछ भी ना बचे। इसको कहते हैं सस्टेनेबिलिटी, और इसमें हम भरपूर काम कर रहे हैं। तो ये था छोटा सा।
नहीं सर, आपकी कंपनी तो बहुत ही ज़बरदस्त काम कर रही है। मैं अभी आता हूँ कि जो आपको प्रॉब्लम्स है, शमीम भाई ज़रा हमें बताइएगा। ओसाका लाइटिंग के साथ तो हमारा एक बड़ा ज़बरदस्त किस्म का साथ है। IEEE फेयर 2024 13th एडिशन में दाखिल हो गया। आपका ये बेसिक कोर काम है। क्रिकेट में तो आपको हम ज़बरदस्ती खींच के लेकर आ गए थे, लेकिन ये तो आप अपने काम से आए हैं, तो क्या फ़र्क देख रहे हैं आप 13th एडिशन में आने के बाद? कुछ अपनी इंडस्ट्री के जो इतने सारे लोग, अब कंपनीज भी बढ़ती चली जा रही हैं, कुछ ग्रो हो रही है, सब जब मर्जर होता है मिल के बैठते हैं।
बिस्मिल्लाहिर्रहमानिर्रहीम। नसीम भाई, बहुत बहुत शुक्रिया, आपने मुझे यहाँ मदऊ किया। ये जो 13 एडिशन है, ये IEEE की बहुत बड़ी कामयाबी है। हमारी जो कंपनी है ओसाका लाइटिंग, ये शुरू से, जब से ये सिलसिला शुरू किया था बदर एक्सपो ने, हम शुरू से साथ हैं। पहले 1-2 हॉलों में होता था, फिर 3 हॉलों में हुआ, आज माशाल्लाह 5-6 हॉलों में 6 हॉलों में माशाल्लाह बड़े बड़े स्टॉल्स। और कितनी बड़ी कामयाबी है कि आपने पाकिस्तान की पूरी क्रीम को, चाहे उसकी फैक्ट्री किसी भी शहर में हो, उसकी इंडस्ट्री किसी भी शहर में हो, आपने एक जगह लाके उसको यकजा कर दिया। तो ये एक बहुत बड़ी कामयाबी है। आप यकीन माने, हम इंतज़ार में रहते हैं कब फेयर आएगा ताकि हम उसकी तैयारी करें। आप बिलीव करें, आज ओसाका लाइटिंग कंपनी अल्हम्दुलिल्लाह पाकिस्तान की नंबर 1 कंपनी बन चुकी है, और इसका जितना क्रेडिट मैं IEEE को दूं वो कम है, बदर एक्सपो को दूं वो कम है। तो माशाल्लाह यहाँ से हमें जितनी शोहरत मिली है, क्योंकि इस एक्सपो के अंदर हमारे जो मुल्क के नामवर आर्किटेक्ट्स वगैरह सब पूरी क्रीम आती हैं यहाँ पे। वो जब आन के देखती है, यार पाकिस्तान में कौन कौन सी कंपनियाँ आ चुकी हैं, कौन कौन सी इंडस्ट्री लग चुकी हैं। पहले आपको पता था हमारे यहाँ इस मुल्क में सारा मल्टीनेशनल कंपनी का राज था। अल्हम्दुलिल्लाह, अल्लाह का शुक्र है, अब पाकिस्तानी कंपनियाँ ग्रो कर रही हैं, वो ऐसी मियारी चीज़ें बना रही हैं और ऐसी कम कीमत में बना रही हैं कि आप देखें, हमारे के जो मुल्क के हालात हैं वो एक बहुत बड़ा टॉपिक है। अगर मैं मुल्क के हालात पे बात करूं कि गवर्नमेंट इंडस्ट्री को क्या सपोर्ट कर रही है, क्या नहीं सपोर्ट कर रही, गवर्नमेंट चाहे जो भी हो, हमें इससे कोई तदारुक नहीं है, किसी भी पार्टी की हो, कुछ भी हो। हम चाहते हैं जो भी गवर्नमेंट आए वो पहले इंडस्ट्री का तहफ़्फ़ुज़ करे, इंडस्ट्री के लिए इतनी आसानियाँ पैदा करे। अब जैसे मेरे भाई माशाल्लाह जो उन्होंने बातें की स्मार्ट सिटी की, यकीन माने मैंने भी फर्स्ट टाइम सुना है। मैंने बहुत सारी चीज़ें नहीं सुनी। इतने ऐसे टैलेंटेड लोग हैं जो, हम तो ये तो अभी मुझसे बात कर रहे थे, हम तो सिंगापुर से मुकाबला कर रहे हैं इसका, जो माशाल्लाह ये जो सिटी बना रहे हैं। तो ये टैलेंट पाकिस्तान में क्यों नहीं है? ये पाकिस्तान में टैलेंट है, हम भी वही अल्लाह की मखलूक हैं जो अल्लाह की मखलूक है, लेकिन वहाँ गवर्नमेंट आसानियाँ देती है, लोगों को एडवांटेज देती है कि भाई ये सारे काम करो, हम आपको रिबेट देंगे, हम आपके लिए ये तहफ़्फ़ुज़ करेंगे, ऐसी ऐसी पॉलिसीज़ लेके आएंगे, हम इंडस्ट्री की 10-10 साल की पॉलिसीज़ बनाएंगे ताकि आप खुल के इंडस्ट्री लगाएं यहाँ पे। लेकिन ऐसा नहीं होता। तो मैं इस हवाले से अपनी एक तो गवर्नमेंट से एक इल्तिजा करूँगा, गुजारिश करूँगा, खुदा के लिए इस मुल्क का सोचें, इंडस्ट्रियलिस्ट का सोचें। इंडस्ट्रियलिस्ट यहाँ अपना सारा जो भी उसके पास फंड्स होता है वो सारा लगाता है और इस मुल्क के लिए करता है, ताकि मुल्क के अंदर बेरोज़गारी ख़त्म हो, मुल्क के अंदर रोज़गार हो,
माशी हालात
बेहतर हों। माशी हालात बेहतर होंगे, इंडस्ट्री लगेगी तो हमें IMF के पास जाने की ज़रूरत नहीं होगी। आज हम IMF के पीछे पड़े हैं भाई, मुल्क का पैसा सारा बाहर जा रहा है, टैलेंट बाहर जा रहा है, नौजवानों के अंदर इतना खौफ पैदा हो चुका है कि 1 साल के अंदर आप देखें कितना टैलेंट मुल्क से बाहर चला गया। क्यों? आप इस टैलेंट को रोकें, ये सारा टैलेंट निकल जाएगा तो मुल्क का क्या होगा? तो हम बूढ़े लोग क्या करेंगे? तो बेहतर यही है, हर चीज़ के लिए गवर्नमेंट सोचे, टैलेंट के लिए सोचे, इंडस्ट्री के लिए सोचे, एक लोगों के अंदर तहफ़्फ़ुज़ पैदा करे। जो एक लोगों के अंदर खौफ की फ़िज़ा पैदा हो चुकी है, इस खौफ को ख़त्म करे ताकि हर एक कोई इंडस्ट्री लगाए, बेरोज़गारी ख़त्म हो। और आज हम अपने मुल्क के लिए कर रहे हैं, कर हम एक्सपोर्ट करें ये सारी की सारी चीज़ें, हम दुनिया को दिखाएं कि पाकिस्तान में इतना टैलेंट है जो हर चीज़ आपको देता है। ये स्मार्ट सिटी आज लाहौर में इन्होंने बनाई है, मैं तो कहूँगा कराची में भी बनाएं, पेशावर में भी बनाएं, फैसलाबाद में, हर जगह बनाएं। फिर ये दुनिया पे जाएं, दुनिया में जाके दुबई में, इधर उधर अफ्रीका में, मिडिल ईस्ट में जाके बताएं, देखें जी हमने पाकिस्तान में ये चीज़ें बनाई हैं।
खासतौर पे इन्होंने माहौलियात की बात की, तो
माहौलियात की बात
सबसे ज़्यादा ज़रूरत।
जी हाँ, उसकी सबसे ज़्यादा हमें ज़रूरत है,
क्योंकि मट्टी धूल हमारे सड़कें जो
बिल्कुल
हैं,
ये हर वक्त हमारे साथ है, हर चीज़ को दूर किया जा सकता है। तो ये सारे काम यहाँ इस मुल्क में हो सकते हैं। तो मैं थोड़ी सी अपनी लाइटिंग से मुतालिक बात करूं आपसे कि अल्हम्दुलिल्लाह ओसाका की जो इस वक्त मसनूआत है इंडोर आउटडोर, आप यकीन माने जिस वक्त हमने एनर्जी सेवर लॉन्च किया था, मल्टीनेशनल कंपनियां 2 महीने की 3 महीने की वारंटी देती थी कि आप 2-3 महीने इस्तेमाल कर लो, हम ख़राब हो तो सही होके दे देंगे। हमने 2001 में एनर्जी सेवर लॉन्च किया और हमने 1 साल की वारंटी दी कि 1 साल के अंदर आपका सेवर लाइट ख़राब हो जाए, आप 11 महीने में ही ख़राब आप नया ले लो।
ये बहुत बड़ी
और
है।
हमने कीमत आधी कर दी उसकी, और आज अल्हम्दुलिल्लाह हमारी एलईडी लाइट्स हैं जो कि 90% सेविंग करती हैं एनर्जी की। आपको पता है हमारे मुल्क के अंदर एनर्जी कितनी प्रॉब्लम है, एक बहुत बड़ा मसला है। तो हम अल्हम्दुलिल्लाह जो भी काम करते हैं पहले मुल्क का सोचते हैं, मुल्क के मफाद का सोचते हैं, आवाम का सोचते हैं कि इनकी कितनी आमदनी है, इनका क्या है, तो वही प्राइस रखो और ऐसी क्वालिटी बना के दो कि किसी के इस्तेमाल में आए।
शमी भाई, एलईडी लाइट्स की आपने बात की, एलईडी लाइट्स का मटेरियल जो बनता है वो मोस्टली हमें इंपोर्ट ही करना पड़ता है, क्योंकि अब तक हम ये जो कंप्लीट जो इसकी एक आर्ट है वो हासिल नहीं कर सके एलईडी लाइट्स का।
पहले ये होता था नसीम भाई, हम फिनिश माल मंगाते थे, बनी हुई चीज़ मंगाई भेज दिया। फिर हमारे से यहाँ ईडीपी एक डिपार्टमेंट है, इंजीनियरिंग डेवलपमेंट बोर्ड, उन्होंने कहा जी हम आप ऐसा करें, इसके जो पार्ट्स वगैरह मैं बल्क की मिसाल दूँ आपको, इसके आप पार्ट्स मंगा के यहाँ असेंबलिंग करें। हमने फिर ये सिलसिला शुरू कर दिया। उन्होंने कहा जी आप पार्ट्स नहीं मंगाएं, आप हर चीज़ यहीं बनाएं, इसका सर्किट यहीं बनाएं, इसकी हाउसिंग यहीं बनाएं, तो हम आपको तहफ़्फ़ुज़ देंगे। तो अल्हम्दुलिल्लाह अब हम इसका जो सारा सर्किट है वो हम यहीं बना रहे हैं पाकिस्तान के अंदर।
माशाल्लाह।
इसकी जितनी भी हाउसिंग है सारा यहाँ हर चीज़ बन सकती है, लेकिन सिर्फ गवर्नमेंट की पॉलिसी जब तक एक इंडस्ट्री को तहफ़्फ़ुज़ न हो तो जब तक ये काम नहीं हो सकता।
कभी इंपोर्ट पे पॉलिसी चेंज है, कभी
कुछ, अब हमें ये नहीं पता, आज हमने इंडस्ट्री लगा ली, इन्वेस्टमेंट कर लिया, कल को हमारे साथ क्या सुलूक होगा। ये सारी चीज़ें प्रॉब्लम आती हैं। कोई बात नहीं, हमारा मुल्क है, हमारा पाकिस्तान है, ये सारी प्रॉब्लम आएंगी, हम सेव करेंगे। पहले अपने मुल्क का सोचेंगे, अपने मुल्क की आवाम का सोचेंगे, मफाद का सोचेंगे, ताकि ये मुल्क जो अल्लाह ताला ने हमें दिया है कितनी बड़ी नेमत, तो उसकी हम कदर करें, हर लोग इसकी कदर कर लें, इसको समझ लें या ये मुल्क क्या है, मुल्क के लिए हम पहले सोचें, तो इंशाल्लाह हमें कोई प्रॉब्लम नहीं आ सकती। क्या कुछ हो सकता है इस मुल्क के अंदर, सब कुछ हो सकता है सर,
सब कुछ हो सकता है। ये हो सकता है अदनान मोईद भाई, इस मुल्क में क्या नहीं हो सकता अदनान भाई, सब कुछ हो सकता है इस मुल्क के अंदर।
देखें, मैं बताता हूँ, मेरा ज़्यादातर टाइम मुल्क से बाहर रहा है। 2021 में मैं पाकिस्तान आया, उस वक्त हमारे हालात कदर बेहतर थे। अच्छा, मैं आया था यहाँ एक विज़न लेकर आया था और एक मतलब आगे का सोच के आया था कि ज़ाहिर है मैं यहाँ से लोग उल्टा वापस जा रहे थे और मैं वापस आ रहा था।
इंडस्ट्री लिंक
जी हाँ, तो इंडस्ट्री लिंक बेसिकली हम लोगों ने जब इस्टेब्लिश की, ये बेसिकली हमने एक अमेरिकन प्रोडक्ट है वेस्टिंग हाउस, ठीक है ना। वेस्टिंग हाउस के नॉर्मली यहाँ पे जो लोग जाने जाते हैं वो अप्लाइंसेस के बिज़नेस से रिलेटेड है, लेकिन वो इलेक्ट्रिकल के बिज़नेस में भी ये मतलब काफ़ी इन्वॉल्व है, ठीक है ना। जो पहली जो थॉमस एडिसन और उस ज़माने में जो लाइट बल्ब और इस तरह का होता तो वेस्टिंग हाउस भी उसमें वन ऑफ द इन्वेंटर था जिसने डीसी करंट बनाया था, ठीक है ना। और उसके बाद लोकोमोटिव बनाया इन्होंने, उस होते होते फिर इलेक्ट्रिकल बिजनेस में आए। आज अगर आप देखें लैंडिंग के ग्रिड स्टेशन में बहुत पहले का 1970 से भी पहले का वेस्टिंग हाउस की प्रोडक्ट्स लगी हुई है वहाँ पे। तो अभी जो हम लोग यहाँ पे हैं बेसिकली हम लोग इन्वेंट्री मैनेज कर रहे हैं पूरी वेस्टिंग हाउस की, पूरे सोल्यूशन दे रहे हैं, ठीक। और जितनी भी प्रोडक्ट्स हैं हमारे पास उसमें बहुत सारी प्रोडक्ट एनर्जी एफिशिएंट्स भी है, जैसे हमारे पास ड्राई टाइप ट्रांसफार्मर्स हैं जो कि बहुत एनर्जी एफिशिएंट है, ठीक है ना। और अगर आप ROI देखें वर्सेस ऑयल टाइप, उसमें आपको ज़ाहिर मेंटेनेंस भी चाहिए होती है और उसमें आपको बहुत सारा काम भी करना पड़ता है, ठीक है ना। इसमें ये मेंटेनेंस फ्री है, इसमें आपने ब्लोअर मारा और ये साफ़ हो गया। इन एडिशन टू डैट में लॉसेस कम है इसके। पाकिस्तान में सबसे ज़्यादा लॉसेस की बात होती है कि हमारे इलेक्ट्रिकल जितना हम जनरेट करें उसमें तो इतना लॉस हो रहा है, उसके बाद फिर हमें मिल रहा है। तो ये जो ट्रांसफार्मर्स हम यहाँ पे जो सप्लाई कर रहे हैं इसके लॉसेस भी बेहतर है, मतलब कम है, ठीक है ना। तो इस तरह की जो प्रोडक्ट्स है ना वो हम लोग यहाँ पे लेकर आए।
इस वक्त जो हमारा बिजली का मसला तो मुल्क का दिखाई देता है, वो तो हर आदमी उसके अंदर, तो आपका तो काम ही सिर्फ, अगर मैं इलेक्ट्रिकल या इलेक्ट्रॉनिक्स की बात करता हूँ, आप तो डिपेंड ही टोटल इलेक्ट्रिसिटी पे कर रहे होते हैं, उसके अलावा आपके पास हल नहीं होता। लेकिन इस वक्त जो सूरत हाल दिखाई दे रही है वो ये कि अगर इलेक्ट्रिसिटी आ भी रही है तो इतनी फ्लक्चुएशन दिखाई देती है कि बड़े बड़े आप सेक्टर्स में जो मशीनरीज ला के लगाते हैं वो डिज़ाइन हुई हुई होती हैं बाहर के लिहाज से कि जहाँ पर जो है वो इस तरीके की फ्लक्चुएशन नहीं आती है। तो आप जो ये ट्रांसफार्मर्स वगैरह बना रहे हैं इसमें फ्लक्चुएशन को कंट्रोल करने का भी कोई?
हाँ देखिए, उसके लिए होता है AVR कहते हैं, ऑटोमेटिक वोल्टेज रेगुलेटर।
हाँ।
ठीक है ना, जो आपकी अगर वोल्टेज ऊपर हो गया तो उसको आपकी जो स्टैंडर्ड लेवल है, फॉर एग्जांपल हमारे यहाँ अगर 220 वोल्ट है, मैं समझाने के लिए बता रहा हूँ, तो 220 हमें कंटिन्यूसली 220 देना है। तो उसके लिए हम लोग क्या करते हैं, एक प्रोडक्ट है ऑटोमेटिक वोल्टेज रेगुलेटर, वो हम बीच में लगा देते हैं, जिसकी वजह से आपकी ये सस्टेन हो जाती है उसी लेवल पे जो आपको चाहिए होती है। ओवर वोल्टेज की वजह से आपके जो अप्लायंसेस है वो डैमेज हो सकते हैं, ठीक है ना, मतलब वो बेकार हो जाएंगे, आपके यूज़ के नहीं होंगे। तो इस सब चीज़ों पे ना ये अच्छा जो आप बता रहे हैं ये बेसिकली देखें बहुत सारी चीज़ें होती हैं यहाँ पे, डिज़ाइन बहुत अच्छा कर रहे हैं। मतलब पाकिस्तान के जितने भी टैलेंट की मैं बात करूँ, क्योंकि मैं तो बाहर भी रहा हूँ, तो बाहर जितने टैलेंटेड लोग हैं उनमें जो नामवर लोग थे वो सारे पाकिस्तान से ही आए हैं, कराची से, लाहौर से, पिंडी से, पेशावर से, तो वो वहीं काम कर रहे हैं। ठीक है ना, जब वो वहाँ इतनी अच्छी इतनी दुनिया की सबसे बड़ी ऑयल कंपनी सऊदी अरामको है, वहाँ अच्छी पोजीशन पे टेक्निकल की जो हेड है वो पाकिस्तानी है। वहाँ की जो यूटिलिटी, जैसे यहाँ पे KE है, NTDC है, वहाँ पे SEC है, ठीक है ना, सऊदी इलेक्ट्रिक कंपनी है, दीवा है, उस तरह वहाँ पे भी अच्छी पोजीशन पे यही लोग काम कर रहे हैं। तो यही लोग वहाँ पे भी यही वो मतलब वो सारा काम कर रहे हैं, वो अपने मुल्क में भी डेफिनेटली कर सकते हैं। वो यहीं से पढ़ के गए हैं, हमारी यूनिवर्सिटी से एजुकेशन ली है उन्होंने, यहीं से एक्सपीरियंस लिया, फिर वो बाहर गए, फिर वहाँ जाके मज़ीद एक्सपीरियंस लिया, उनकी ट्रेनिंग हुई, उन्होंने उनका सिस्टम डेवलप किया, और आज हम देख लें कहाँ पे हैं वो कहाँ पे। तो हमें अफसोस तो होता है इस चीज़ का, लेकिन ये है कि हमारे पास टैलेंट बहुत है, ठीक है, हमारे पास बहुत टैलेंट है, लेकिन हमारे पास टैलेंट को की कोई यूटिलाइजेशन नहीं है यहाँ पे कोई, ठीक है ना, हमारे टैलेंट को सही जगह पोजीशन नहीं किया हुआ है, ठीक है ना। अगर ये हम कर लें तो बहुत सारी चीज़ें सही हो जाएंगी। आपका सवाल था कि क्यों इतनी फ्लक्चुएशन बार बार होती है, उसका सोल्यूशन
को कंट्रोल, देखिए वो तो नहीं रुक सकती थी कि सऊदी अरब में काम कर रहे हैं वो SEC में,
जी हाँ,
वहाँ पे इस तरह फ्लक्चुएशन नहीं होता, वहाँ पे एक लेवल से आपको इलेक्ट्रिसिटी मिल रही है।
सही।
यहाँ पर क्या है कि कहीं कुंडों का मसला है, वहाँ पे उन्होंने लोड शेडिंग डिफरेंट करनी है, कहीं कुछ और करनी है। तो जो आप प्राइवेट सेक्टर में काम करें, कोई ऐसी चीज़ें प्रोडक्ट होनी चाहिए जो इस चीज़ को सपोर्ट कर रही हूँ, क्योंकि हमारे वहाँ तो वो बिल ज़्यादा देने से कोई उनको टाइम नहीं मिल रहा। तो आप लोग कोई लोगों की सपोर्ट के लिए कहाँ पर हैं?
देखें, इसमें बहुत सारी चीज़ें हैं, बहुत सारे सिस्टम जो हमारा है वो आउटडेटेड सिस्टम है जो हमारे लगे हुए हैं, जो KE के सिस्टम में लगे हुए हैं।
जी, मैं उसी पे बात कर रहा था।
हाँ, तो मैं जैसे अगर आप एक सब स्टेशन है, अगर आप उसको खोलेंगे तो उसमें वही ट्रॉली टाइप का पुराने ज़माने का वैक्यूम सर्किट ब्रेकर या SF6 सर्किट ब्रेकर लगा हुआ है, जो कि SF6 तो इन्वायरमेंट के लिए अच्छा नहीं है, यूरोप में तो ये बैन हो जाएगा 2-4 साल में, ठीक है ना। उसकी जगह वैक्यूम आ गई, टेक्नोलॉजी आ गई, और प्रेशराइज एयर प्रेशराइज सर्किट ब्रेकर्स आ गए हैं। हमें वो सारी चीज़ें अगर वो हम उसको मतलब क्या करें कि उसको रिप्लेस करें नई चीज़ों से, ठीक है ना, जो हमारे अपडेटेड चीज़ें हैं उसको करें। इसी तरह जैसे हम लोग रिन्यूएबल पे बहुत काम हो रहा है यहाँ पे, सबसे बड़ा सस्टेनेबल तो यहाँ पे यही है कि आप बैटरी ऑपरेटेड और सूरज की रोशनी से आप इलेक्ट्रिसिटी जनरेट कर रहे हैं। इस वक्त जितनी भी दुनिया है वो सारी के सारी सोलर पे जा रही है, ठीक है ना। हमारे यहाँ अभी तक अगर आप देखें इंडस्ट्री,
दुनिया जा रही है,
पूरी दुनिया सोलर पे जा रही है। मैं तो बाहर देखूँ तो सऊदी अरबिया देख लें, जिनके पास ऑयल है, ठीक है ना, उनके पास ऑयल है, उनको क्या ज़रूरत है कि वो
सोलर
इलेक्ट्रिसिटी उस पर जाएँ, ठीक है ना। लेकिन क्योंकि उनको चाहिए इन्वायरमेंट फ्रेंडली और सस्टेनेबल वो चाहिए, तो इस वजह से वो सोलर पे जा रहे हैं, ठीक है ना। हमारे यहाँ क्या है कि हमारे यहाँ अभी तक जो है ये है इंडस्ट्री लेवल पे है, लेकिन ज़्यादातर महदूद है हमारे रेजिडेंशियल लेवल पे, वो भी क्योंकि बिजली का बिल बहुत ज़्यादा है, ठीक है ना। उसको कंपनसेट करने के लिए लोग क्या कह रहे हैं कि ये फ्री बिजली है तो ये हम इसको यूटिलाइज़ करें। तो हमारे यहाँ इस तरह से वो हो रहा है सारी चीज़ें। हमारे सिस्टम को सबसे पहले अपग्रेड करना है, हमें नई टेक्नोलॉजी लेकर आनी है, और ये हो रहा है, इस पर ऐसा नहीं है कि काम नहीं हो रहा है, लेकिन उस पेस से नहीं हो रहा जिस पेस से होना चाहिए। उसकी वजह ये है कि ज़ाहिर फंड चाहिए, ठीक है ना। आप रिप्लेस करेंगे, वो सिस्टम सही चल रहा है, वो 25 साल पुराना है, हर की एक लाइफ होती है, तो लाइफ साइकिल आप ब्रेक करके आप नई टेक्नोलॉजी उसकी जगह लेकर आएँ। तो ये हमारे यहाँ इस तरह का कोई चीज़ ज़्यादा हो नहीं रही है।
हाँ, इनोवेशन पे काम कम हो रहा है। अगर देखा जाए दूसरे लफ्ज़ों में हम ये कह सकते हैं कि हम जो चीज़ को लेके चल रहे हैं वो
वही
लेके
चले
ही
जा
चल
रहे
रहे
हैं,
हैं
वही
बस।
लेके चले, उसी को हम रेट्रोफिट करके उसी में चीज़ें चेंज करके उसी को हम वो करते हैं, लेकिन हम अपग्रेड नहीं कर रहे हैं, हम रेट्रोफिट कर रहे हैं। रेट्रोफिट मतलब हमने पुरानी चीज़ निकाली, नई चीज़ फिट
सर
कर।
हम अपने नए बच्चे जो नया जहन आ रहा है उससे कितना काम ले रहे हैं, जो हमारे इंजीनियर्स आ रहे हैं, क्योंकि ये प्लेटफॉर्म भी इंस्टीट्यूट ऑफ इलेक्ट्रिकल एंड इलेक्ट्रॉनिक इंजीनियर्स का दिखाई देता है, तो हमारे जो इंजीनियर्स आ रहे हैं बच्चे वो एक नए ख्यालात नई सोच के साथ आ रहे हैं। तालीम में भी फ़र्क पड़ा है, किताबों में सिलेबस का भी फ़र्क है, हम उनको कितना यूटिलाइज़ कर रहे हैं, क्योंकि उनकी क्रीम यहाँ रुकने को तैयार नहीं हो रही है सर।
बिल्कुल, देखिए उनको अभी अभी यहाँ पे ये देखिए मल्टीनेशनल तो तकरीबन इलेक्ट्रिकल फील्ड में ज़्यादातर वापस चली गई है, ठीक है ना। अच्छा वापस गई है तो ऐसा नहीं है कि वो वापस चलेगी, वो पार्टनरशिप अपनी प्रोडक्ट दे के गई है।
हाँ, यहाँ पे करंट लोगों
यहाँ
ने
पे,
ले लिया है।
बिल्कुल
सर वो चला लेंगे उस तरीके से, हम तो खुद बेचने में लगे हुए हैं अपने सारे इदारे। आपने अगर किसी मल्टीनेशनल से खरीद भी लिया,
जी हाँ,
क्या हम इतने कैपेबल हैं कि हम उसको उस तरीके से रन कर लेंगे? हमने सारे इदारों का तो हाल जो किया है वो हमारे सामने।
हाँ देखिए उस पर बैकअप सपोर्ट उनकी फिर भी रहेगी, वो ऐसा नहीं है कि बिल्कुल मैदान में अकेला छोड़ के चले गए,
जैसे IEEE की तरह कह रहे हैं।
हाँ जैसे फॉर एग्जांपल किसी वेस्टिंग हाउस है, ठीक है ना, वेस्टिंग हाउस है, अब यहाँ पे उनका प्रिंसिपल ऑफिस भी है, ठीक है ना, ठीक है वो मैन्युफैक्चरिंग यहाँ पे नहीं कर रहे हैं लेकिन मैन्युफैक्चरिंग में मदद कर रहे हैं, ठीक है ना। वो OEM यानी ओरिजिनल इक्विपमेंट मैन्युफैक्चरर जो है उनको बता रहे हैं कि भाई तुम हमारा ये डिज़ाइन लो, ये लाइसेंस लो और तुम यहाँ पे बनाओ।
कंपनी उसी नाम से,
कंपनी दूसरे नाम से पाकिस्तानी है लेकिन ब्रांड जो है वो वेस्टिंग हाउस का यूज़ कर रहे हैं, ठीक है ना। फॉर एग्जांपल मैं आपको बताता हूँ, जैसे स्विच गियर है, हमारी एक प्रोडक्ट है स्विच गियर। अब स्विच गियर जो है ये एक डिज़ाइन प्रोडक्ट होती है, हर आदमी नहीं बना सकता ये, ठीक है ना। इसकी टेक्नोलॉजी बाहर से यहाँ पे ट्रांसफ़र हुई, मैंने खुद ट्रांसफ़र की है, ठीक है ना, मैं इस पे इन्वॉल्व हुआ हूँ,
ठीक है,
ठीक है। पहल को दी है हमने, सैयद भाई एक ज़माने में होते थे उनको दी थी मैंने, ये अरीवा TND होती थी पहले, इनको दी थी मैंने। तो वो जो टेक्नोलॉजी यहाँ ट्रांसफ़र होती है तो वो यहाँ पे उसको लोकलाइज़ करते हैं। जब ये इसको लोकलाइज़ करते हैं तो उसमें इन्वॉल्वमेंट होती है जो NED के जो लड़के आते हैं ना, या यूनिवर्सिटीज़ के जो लड़के आते हैं, तो इस यहाँ पे हम इनको इन्वॉल्व करते हैं उसकी R&D में, ठीक है ना, ताकि आप बताएं कि आपके लिहाज से वो फ्रेश ब्रेन होता है, ठीक है ना, वो ज़्यादा सोच सकता है और वो ज़ाहिर है उनका एक्सेस होता है नेट पे और उस पर वो। पहले हम लोग जब हमारे ज़माने में तो ये था हम बुक पढ़ के सारी चीज़ डेवलप कर, अब तो हर चीज़ नेट पे अवेलेबल है। तो उनके पास 10 तरह की चीज़ें, AI आ गई है, IoT आ गई है, ये सारी चीज़ें आ गई, तो ये सारी चीज़ें जो ना ये लोग और अच्छे तरीके से वो करते हैं। हमारी ऑफिस के बराबर में एक और ऑफिस है, उसमें एक लड़का है NED का, हम लोग एक मीटर डेवलप कर रहे हैं IoT से, जिसमें हमारा ये सोलर और जनरेटर और अगर KE है या NTDC है तो उसकी पूरी की पूरी जो ना हम लोग मॉनिटर कर रहे हैं उसकी परफॉर्मेंस रिमोटली।
अच्छा,
IoT की तरह ये लड़के खुद डिज़ाइन कर रहे हैं और ये पहली दफ़ा पाकिस्तान में होगा, तो ये बड़ी अच्छी चीज़ है। तो ये मैं देख के, जब मैं देखा तो मैंने कहा ये हमारे लड़के हैं, हमारे मतलब इलेक्ट्रिकल ग्रेजुएट्स हैं, तो हमें बड़ा खुशी हुई है देख के यार पाकिस्तान में भी ये काम हो रहा है। तो मैं तो पर्सनली पाकिस्तान इसीलिए आया हूँ कि मैं कुछ कर सकूँ।
नहीं सर, पाकिस्तान है तो हम हैं, पाकिस्तान, और हम दुनिया में जहाँ भी चले जाएं, और सर एंड ऑफ द डे पाकिस्तानी याद आ रहा होता है। आप यकीन करें, मैं कोई जियो में मैंने 21 मुल्कों का, मैं जियो का माइक पकड़ा जाके ये रिपोर्टिंग की, यूरोप शोरप जहाँ क्रिकेट होती है हर जगह पे, IPL कवर करने गए, इंडिया इतना घूमा शायद हिंदुओं ने भी नहीं घूमा होगा। 2005 में तो 16 शहर गए थे हम, तो इतनी अल्लाह ने दुनिया दिखाई। लेकिन एंड ऑफ द डे जो सुकून यहाँ पर आता है ना कि एक अपनी मर्जी से घूम रहे हैं, सर हमारे हालात कुछ बेहतर कर दें, जो आप बात कर रहे हैं। अली भाई आपका विज़न जान के बहुत खुशी हुई, मुझे बहुत अच्छा लगा। आपने खुद शमीम भाई ने भी ये बात की कि एक विज़न दिखाई दे रहा है, आप जिस अंदाज से काम कर रहे हैं। हमारी जितने स्टेक होल्डर्स बैठे हुए हैं, आप पहली मरतबा यहाँ पे पार्टिसिपेट कर रहे हैं, क्या कुछ आपको नया दिखाई दिया कि इन लोगों के साथ मिलके, जिस तरह आपने जो अपने स्मार्ट सिटी बना रहे हैं आप, ज़बरदस्त किस्म के आपका काम दिखाई दे रहा है, लाहौर में भी, इस्लामाबाद में भी, लेकिन इतने स्मार्ट लोग बैठे हुए हैं, तो कुछ चाहे आप पावर सेक्टर में बात कर लें या कुछ और लाइटिंग की बात कर लें, तो कुछ नई चीज़ दिमाग में आई है IEEE में आने के बाद कि अब मेरा स्मार्ट सिटी और ज़्यादा स्मार्ट ऐसे होगा?
जी बिल्कुल नसीम साहब, मैंने जैसे आपको बताया कि स्मार्ट सिटी के 3 लेयर्स हैं। एक बेस होती है सस्टेनेबल डेवलपमेंट, वो हम कर चुके हैं, और अगर हमने इसको स्मार्ट करना है, जो कि जिस स्मार्ट मीन्स के डिजिटल करना है, ये डिजिटल ड्रिवन होती है, तो ऊपर हो गई IoT हो गई, सॉफ्टवेयर्स हो गए, तो इसको जो दरमियान की लेयर है जो सस्टेनेबल डेवलपमेंट को और सॉफ्टवेयर के दरमियान की लेयर है उसको हम इलेक्ट्रॉनिक्स कहते हैं। तो जब हम यहाँ आए हैं तो यहाँ पे इन लोगों को भी हमने अपने आप को इंट्रोड्यूस इसलिए किया है कि हम इनको एक ऐसा एवेन्यू दे रहे हैं जिसमें ये बहुत ज़्यादा इन्वेस्ट और कंट्रीब्यूट कर सकते हैं, और ये विन विन सिचुएशन होगी इनके लिए भी और हमारे लिए भी। हम इनको मौके दे रहे हैं एक्सपेंशन का, न्यू आइडियाज़ का। फॉर एग्जांपल जैसे इन्होंने बताया कि इनके पास ट्रांसफार्मर्स हैं, स्मार्ट ट्रांसफार्मर्स हैं, हम इनके साथ बिल्कुल कोलैबोरेट कर सकते हैं। ये सस्टेनेबल है, ज़्यादा एफिशिएंट है, और हम क्यों नहीं इनको करेंगे। जैसे
ओसाका लाइट्स इन्होंने बताया जो कमाल कमरे से लेके हर जगह पे काम कर रहे हैं।
इसके ये इतनी ज़्यादा इम्पोर्टेंस रखता है लाइटिंग सस्टेनेबिलिटी में, क्योंकि ये एनर्जी कंज्यूम करता है, और हम इस कोशिश में हैं कि हम ऐसी स्मार्ट लाइटिंग्स को इम्प्लीमेंट करें जो कि लेस एनर्जी कंज्यूम करें, या उस वक्त एनर्जी कंज्यूम करें जब उनकी ज़रूरत है। फॉर एग्ज़ाम्पल जैसे मैं आपको बताऊं कि हमने अपनी स्ट्रीट लाइट्स और मेन जो बुलेवार्ड्स हैं उसके ऊपर जो हमने लाइटिंग की है वो स्मार्ट है। फॉर स्मार्ट मीन्स